Assalamu alaikum wa rahmatullah. I'd like to welcome everybody to our online forum. And today we have actually a unique and a special event to cover all about respiratory care. And will be the introduction for our conference in September. Our conference, inshallah, will be on 13, 14, and 15 of September 2024. And we'll continue the talks about respiratory care in our physical conference in September, inshallah. So we'll consider today the introduction for our conference. And we have today, as I said, a unique and a special event. We have 4 eminent speakers to tell us all about respiratory care in the care of the newborns. I'd like to welcome whoever is attending. I'd like to welcome our speakers, our chairman, and my colleagues who are attending this special event. We have our first chairman and moderator of the coming 2 sessions will be Dr. Iyad Saada. And Dr. Iyad Saada actually is a dear colleague. I've known Dr. Iyad now for at least for the last 10 years. And Dr. Iyad Saada is currently the head and the chairman of the neonatal unit in Mediclinic Airport Road. I'd like to thank Pearl Management and Dr. Mafaq Shimali and his colleagues, however, running and overseeing these online events and actually all the physical events that we introduce. Take this chance also to invite you for our physical conference in September and all the other activities that we do, including the respiratory course that we introduce periodically in Dubai and Abu Dhabi and in all the other countries of the Middle East. So now I will like to leave you with Dr. Iyad Saada, who will moderate the coming sessions, inshallah. Dr. Iyad Saada.
Hi, hello, Dr. Hisham. Hello?
Yes, Dr. Iyad, you can take over, please.
Can you hear me?
Yeah, we can hear you and you can take over. Please introduce our first speaker.
Okay, but I don't know why it's not working. You give me something.
But your camera is off.
But I don't know why.
Dr. If no camera, okay, just introduce voice then.
But I don't know why it's not working. Just a moment. I want to go back. I try to activate.
Yeah, just until Dr. Iyad fix his video streaming, I just would like to remind you that we will take the questions after each presentation. So the presentation will be for about 40 minutes and we will leave 5 minutes, around 5 minutes for questions. So if you are interested to ask questions, please write it in the chat section, and then we will, Dr. Iyad, we will answer these questions after each presentation. So just to make it easy for our speakers. Questions will be after each presentation.
Thank you, Dr. Hisham. I don't know what happened with the camera. Anyway, the first is our speaker will be Dr. Martin Kessler. Dr. Kessler is a native of Czech Republic and graduate of McGill University Medical School in Montreal, Canada. He's a professor of pediatric at Brown University and remains clinically active at Women and Infant Hospital of Rhode Island. Dr. Kessler is the neonatal research network for 12 years and remains very active as a doctor, author, and editor. His area of research, the volume target ventilation, delivery room stabilization, and high frequency ventilation, pulmonary hypertension, and bronchopulmonary dysplasia. Today, Dr. Kessler will talk to us about the novel neonate ventilation strategy. Welcome, Dr. Kessler. Hello, Dr. Kessler. Hello.
Hello, are you asking for me?
So they changed, because for me now Dr. Martin will be, maybe they change.
Could you please start with Dr. Ahmed, since Dr. Kessler is not here, not available for this now?
Hello. Sorry, some change in the program. So Dr. Amit will start our program today. Dr. Amit will talk to us today about non-invasive ventilation. Dr. Amit, he is the associate professor in the Department of Pediatric at McMaster University. And he also the staff as neonatologist at the McMaster Children's Hospital. He had the Master of Science degree in the clinical epidemiology in 2017 from the University of Toronto. And his main area of clinical and research is non-invasive respiratory support. He has published more than 25 articles in peer-reviewed journals since joining the faculty. And beginning the neonate respiratory support, management, and outcomes. He formed and chairs the Prevent BPD working group aimed at standardizing practice toward preventing bronchopulmonary dysplasia, is the respiratory lead physician for the MECT NICU, and is the national co-chair of the lung health group of the EPIQ, evidence-based practice for improvement in quality initiative. Welcome, Dr. Amit, and we start by the non-invasive ventilation.
First, thank you very much for this kind introduction, and thank you to the organizers for asking me to speak at this event. It's a great honor, and I will share my screen. Do my slides show on the screen to everyone? This topic is non-invasive respiratory. Okay, sorry, that's so I have to open a different version. I apologize. Okay, so I hope this these slides show.
Yes.
Perfect. Okay. Well, thank you very much again, and apologies for being a little bit late. I thought I was starting at a little bit later. So my talk is entitled Non-Invasive Support in Preterm Neonates. I'll go through the evidence, challenges, and future directions in this field as I see it. I don't really have any disclosures or conflicts to declare, but the one thing I will say is that most things I will talk about in this talk are really the tip of the iceberg, because for many of these individual topics, they can be hour-long talks of their own. And the second disclosure that I'll say is that I'll rely heavily on systematic reviews and meta-analyses, and I'll show you those references, and the audience members can go and look at those references in greater detail at a later time for more detailed review. So for the outline of the talk, I'll first talk about the role of non-invasive respiratory support and why we even use it. Then I'll talk a little bit about the overview of the various types of non-invasive modes. And finally, I'll talk about evidence, limitations, and future directions with a particular focus on CPAP and NIPPV. The reason for that focus is because CPAP and NIPPV are still the most commonly used forms of non-invasive support that we use in most NICUs across the world. So first, I'll talk about why do we even talk about non-invasive respiratory support. So we all know and believe that compared to invasive ventilation, non-invasive support leads to less volume trauma and less barotrauma. It also avoids the cardiovascular and cerebrovascular instability that's related to intubation. It avoids subglottic stenosis and tracheal lesions that are associated with long-term mechanical ventilation. It can also avoid ventilator-associated pneumonia. There are a number of animal model studies that have looked at the comparison of non-invasive support with CPAP as the prototype compared to invasive mechanical ventilation and their impact on lungs. And I'm showing you these two classic references that often get referred to in any animal review on this topic. So the first study is by Dr. Alan Jobe, that everybody knows, and his group, and they studied a group of preterm lambs. And the second one is by Dr. Thompson and group from the Baboon Lab in San Antonio, Texas. And both these studies have shown that compared to invasive mechanical ventilation, short-term use of short-term CPAP or earlier extubation to CPAP leads to better pulmonary lung function characteristics and also reduced inflammatory markers. There was also a few years ago a systematic review on all studies that have looked at, or all animal model studies, I should say, that have looked at the use of CPAP or other forms of non-invasive support compared to invasive mechanical ventilation. And they included 21 studies in this review. And that's a fairly recent review still. And they conclude that while there are some limitations in the available data, the available data does suggest that, that there is enough evidence to support the use of CPAP over mechanical ventilation, early extubation to CPAP, and surfactant supplementation from these animal data. So the animal data is actually fairly convincing that avoiding invasive mechanical ventilation is better. But what about clinical data from humans? So this is a systematic review that was done by George Schmolzer, and who's in Edmonton now in Canada. And they reviewed the available clinical data. And what they found is when looking at the outcome of death or BPD, these are all the classic trials that have compared early CPAP to early routine ventilation. And I think many of in the audience will be familiar with these studies. So the Morley 2008 is the COIN trial, the support trial, I think everybody's familiar with, and also data from Michael Dunn, the Vaughan data, and also the South American study. And you can see that the pooled estimate of death or BPD is reduced when early CPAP was used instead of early routine mechanical ventilation. When looking at the individual components of death or BPD, These trended towards being lower with the use of CPAP, although did not meet statistical significance. But despite the limitations in the human data, and as you can tell, the human data is not as compelling as the animal data, but regardless, we have seen a significant paradigm shift in neonatal respiratory support. And in fact, in the Canadian Neonatal Network, 70% of all respiratory days that are in the non-invasive form. So if you look at all days of support through any form of respiratory support, 70% of them are in the way of non-invasive form. And over the last 10 years, this number has gone up. It used to be 50% 10 years ago, and now it's close to 70% consistent. So we are using non-invasive support a lot more. So with that introduction, we've covered why we would do non-invasive respiratory support. So now we'll talk about an overview of the variety of different modes. Now, this review is from Germany, and it's a little bit old, as you can tell. The reference is from 2011. And this group has actually updated their review of this. But I do think that it's still a very relevant review because this flowchart I really like. It really puts all the different forms of non-invasive support in a nice contextual diagram. Now, the first thing that I will suggest is that instead of using non-invasive ventilation support, that we should be using the term non-invasive respiratory support. I think it's a more general term. And part of the reason for using NRS, or non-invasive respiratory support, in favor of NIV, or non-invasive ventilation support, is because some ventilators use NIV to mean what we understand to be NIPPV, or it gives this implication that we're actually actively ventilating the babies. So my suggestion would be that we should all collectively be using the term non-invasive respiratory support. Then the flow diagram gets divided into constant airway pressures, and these are forms of support like CPAP, where again, the airway pressure is constant. Now, CPAP can be further subdivided into constant flow CPAP, such as conventional ventilator-given CPAP or bubble CPAP, where the flow level is constant. It could also be variable flow CPAP, and that refers to devices such as infant flow, and there are some other European devices that use the Benfiesta valve. So those are different ways of administering CPAP, and we'll touch on that a little bit later. The other form of constant airway pressure given non-invasively is with the use of high flow nasal cannula. And that's something that we'll briefly touch on as well. The other big arm is variable airway pressure. So that's when the pressure administered at the level of the airway is deliberately changing. And the classic example of that is non-invasive positive pressure ventilation, or nasal intermittent positive pressure ventilation. The other forms of that are biphasic CPAP and also nasal high frequency ventilation. And this is coming up more and more. And a lot of recent studies have been done on nasal high frequency in the last number of years. So now that we have a bit of an overview of the different types of modes, the question arises when to use non-invasive support. And the brief answer to that is whenever possible in place of invasive mechanical ventilation, but as long as the patient is comfortable and adequate gas exchange is achieved. And I think we can think of this in two different time points. We can either think of it as a primary support before invasive mechanical ventilation is even instituted, or the other point we can look at is post-extubation support, when invasive mechanical ventilation is being discontinued, and more or less people are trying to discontinue it as early as possible and transition over to non-invasive respiratory support. Having said that, the optimal time to make that transition still remains fairly unclear. But these are the two major forms of indications of when we might use non-invasive support, as long as it's safe to do so. So we'll first focus on primary non-invasive respiratory support use. So this is in place of routine mechanical ventilation. And we'll use CPAP versus NIPPV as the prototypical comparison, because these are the modes that are most commonly utilized. The Cochrane review on this topic was last updated in July of 2023 by Brigitte Lemire and the group and her group from Ottawa, along with others from Australia and worldwide. The latest update of the Cochrane review has 17 trials, close to 2,000 infants, But an important thing to recall and remember is that even though this is use of NIPPV versus CPAP as a primary support mode, it did include infants or studies where patients were briefly intubated and received surfactant. So a patient may have gotten surfactant to ensure was intubated, given surfactant, the breathing tube was taken out, and that was still counted as primary or early NIPPV or CPAP. And that's an important thing to remember, because if you are to apply these results to an infant who has not yet received surfactant, there can be some issues. And I'll touch on that a little bit later as well. The other important limitation to remember is that most trials actually included babies that were gestational age between 28 and 32 weeks. So the amount of data on babies less than 28 weeks in this kind of a comparison is still fairly limited. Nevertheless, with those limitations in mind, you can see the respiratory failure, need for intubation, and chronic lung disease were all reduced with the use of NIPPV compared to CPAP. However, there was no difference in pneumothorax, severe IVH, or mortality. All of these outcomes that were significant were of low to moderate certainty of evidence. One other limitation to keep in mind, and Dr. Kessler and I reviewed all of this and published this just earlier this year, is that when you look at the individual settings on CPAP versus NIPPV, and these are all the studies that have been included in the previous Cochrane review that I just mentioned, you can see that the CPAP settings lead to a mean airway pressure that's much lower than what would be given through NIPPV. So as an example, I'm just going to use the study by Kishore from 2009 to highlight this. And you can see that the CPAP pressure was 5, whereas the NIPPV pressure was 15 to 16 on 5 at a rate of 50, which would yield a mean airway pressure of approximately 7 or 8 centimeters of water. And for the majority of the studies, when failure criteria were met for either CPAP or NIPPV, in most studies, not all, but in most studies, the next step was intubation and mechanical ventilation. And this is not the way most of us are practicing anymore. Most of us are using rescue modes of non-invasive support if CPAP of 5 were to fail, or using higher levels of CPAP and even sometimes beyond CPAP of 8. So to summarize non-invasive support as a primary mode, there is clinical evidence to support some form of non-invasive support as a primary mode versus routine intubation based on both animal data and also the clinical trials that have been summarized by Georg Schmolzer in 2013 in the review I showed you. But there are still many unknowns. The risk-benefit profile of CPAP versus NIPPV is still unclear because of some of the limitations I've alluded to earlier. The gestational age cutoff, where non-invasive respiratory support is superior to routine intubation, still remains unclear because, like I said, some of the studies that have been done in humans have really been at 25 weeks and above. So is non-invasive support really superior to mechanical ventilation at 24, 23, and 22 weeks? That is still not known. And finally, criteria for rescue intubation. So when you do start a baby on non-invasive support, when to actually intubate, give surfactant, that also remains relatively unclear. And what I've just stated is further complicated, or the new factor that has come into the picture is minimally invasive surfactant. And many of you will be familiar with the use of this modality. Many of you have even probably adapted this into your units. But this has now been increasingly shown that this may be beneficial. And what it means is that surfactant administration may not be dependent anymore on mechanical intubation and mechanical ventilation. However, there's still very limited experimental data in extremely preterm neonates of less than 28 weeks. But what this means is that over time, we're going to see more and more use of minimally invasive surfactant, which may allow for more and more use of non-invasive respiratory support as a primary form, and avoiding the need for intubation and mechanical ventilation altogether. So now let's talk a little bit about non-invasive respiratory support as a post-extubation mode. In contrast to PICU and adult ICUs, most preterm neonates require post-extubation respiratory support. And again, the prototypical modes still remain CPAP and NIPPV. So similarly, I'll review the Cochrane database review that was last updated in July of 2023. This included 19 trials, 2,700 infants, and one caveat to know is that this included studies where some or all patients received synchronized forms of NIPPV, which may or may not be available in your units. This review also had very limited data in infants of less than 28 weeks gestation. Respiratory failure, need for intubation, and pulmonary air leaks were all reduced with the use of NIPPV versus CPAP at a low to moderate certainty of evidence. And there was no difference in abdominal distension, GI tract perforation, neck, chronic lung disease, or mortality. However, very similar limitations compared to, as I showed you earlier, in the Cochrane review for primary use. So again, I'm going to use one of these studies as an example. So when you look at the study by Moretti, for instance, they were using CPAP pressures in the range of 3 to 5 centimeters of water, whereas NIPPV was being used with the peak pressure between 10 and 20, PEEP of 3 and 5, and a rate that was similar to the pre-extubation rate. And what this means is that post-extubation, the mean airway pressure as delivered by NIPPV was probably at least 2 or 3 points higher than what was being delivered via CPAP. And any benefit that I showed you in the previous slide, it's difficult to know. Is it something about the flow characteristics of NIPPV directly, or is it the fact that simply higher mean airway pressures were being delivered with the use of NIPPV versus CPAP? So our group in the Canadian Neonatal Network, we did a study looking at how does CPAP compare to NIPPV in the real world when higher CPAP pressures are permitted, and also when rescue with alternate modes are allowed, which is how real world practice is nowadays. What we found was that CPAP was not non-inferior to NIPPV for failure within 72 hours, which means that CPAP did lead to more failure within the first 72 hours. But the more important outcome, which is reintubation within 72 hours and 7 days, we did show that based on our data set, CPAP was in fact non-inferior to NIPPV for reintubation within both those timelines. And what this suggested is that if you were to use CPAP as an initial post-extubation mode, that might actually be quite reasonable. And as the initial post-extubation mode, as long as alternate rescue strategies are available. So as long as you are able to either go up on CPAP levels that are higher than what you started with, or using NIPPV or other forms of non-invasive respiratory support as rescue. And if all of that is permitted, then what we showed is that CPAP is actually not inferior to NIPPV. And this may be particularly germane or relevant to centers where NIPPV devices are not available, because CPAP can be delivered using much simpler devices, including bubble CPAP devices. So to summarize the take-home points for when to use non-invasive support, as a primary support mode, we reviewed that it may improve outcomes. However, the gestational age cutoff for the optimal risk-benefit ratio remains unknown. And the use of minimally invasive surfactant treatment may enhance the ability to use non-invasive support as a primary mode more and more in the years to come, including in lower and lower gestational age infants. I would suggest caution with the use of NIPPV or even the use of higher levels of CPAP before surfactant has been given because of some of the limitations I reviewed in the use of primary comparisons of NIPPV and CPAP. Following extubation, NIPPV does appear superior to CPAP. However, remember that there are discrepant mean airway pressures used between the two modes, and also there are limited data in babies that are less than 28 weeks gestation. And based on real-world data, we did show that CPAP may be non-inferior with respect to the outcome of reintubation. Now we'll briefly touch on high-flow nasal cannula. So as a primary mode, this is a systematic review done a few years ago now, but I think the messaging is still very relevant. As a primary mode, high flow will lead to a higher risk of treatment failure compared to CPAP. And in two of the largest studies, treatment failure with high flow was rescued with CPAP. So if you are a center that is using high flow as a primary support mode, you have to be prepared that up to a quarter of them, up to 25% of them may actually fail and need to be rescued with CPAP. And across the two modes, there was no difference in BPD and or mortality. But once again, this is a common theme that comes across. There are very limited numbers of patients of less than 28 weeks gestation included in a comparison of high flow versus other modes as a primary support. When looking at high flow as a post-extubation support form, there's no difference in efficacy outcomes. There's no difference in BPD and or mortality. But once again, there are limited numbers of patients of less than 28 weeks of gestation included. With these data, there are some centers that are using high flow as a post-extubation support mode in babies that are older than 28 weeks gestation and birth. But again, you have to be familiar with the mode. You have to know how best to use it. And there still may be a risk of failure that may require rescue with other forms of non-invasive respiratory support. We'll now briefly touch on non-invasive high-frequency ventilation. This is a form that's been increasingly studied, and in the last 4 or 5 years, a number of randomized controlled trials have been published. Till now, there are a total of 10 RCTs that have compared this against CPAP and some other forms of non-invasive support. And this was summarized by Wang et al. in the archives last year. And what they found is that the failure rates of the assigned mode and or the need for intubation was lower with non-invasive high-frequency ventilation with a relative risk of 0.45. That's the pooled relative risk of 0.45. That was statistically significant. However, most studies have not reported any difference in the incidence of bronchopulmonary dysplasia. But I'm going to point out some limitations here again. Generally, the populations and indications for use are quite heterogeneous. Most RCTs still, again, did not use similar mean airway pressures as the control group. In this table, I have summarized all the studies that are available comparing non-invasive high frequency with other forms. And only the studies labeled in green are the ones where they attempted to compare non-invasive high frequency ventilation with the control group at an equal mean airway pressure. All the other studies that are marked in red did not compare these modes at equal mean airway pressure. So once again, the question remains that any benefit that's seen with non-invasive high frequency ventilation, is it because of the mode itself, or is it simply because the mean airway pressure was higher with this use compared to CPAP? So for example, if you look at Chen 2019, non-invasive high frequency mean airway pressure is at 10 with a range of 5 to 16, but CPAP is at 6 with a range of 4 to 8. And these are quite discrepant mean airway pressures. And finally, and this applies to all the different studies I've talked about so far in terms of RCTs, none of these studies are blinded to clinicians, so that does introduce an element of subconscious bias. And that's why the certainty of evidence from all of these data are somewhat limited. I do want to inform the audience that there are some upcoming Cochrane network meta-analyses that our group is conducting, a collaboration between us at McMaster, the University of Toronto, and also Australia. We are looking at 7 different modes: CPAP, high CPAP, defined as more than 8 centimeters of water, NIPPV, high flow, non-invasive high frequency ventilation, and others. We do expect to have this published in 2025, but we did share our preliminary results at PAS in Toronto just last week. So now that we've talked a little bit about the different modes, evidence, and their limitations, we'll talk a little bit more practically about how to use these different non-invasive respiratory support modes. We'll first talk about devices. So when it comes to CPAP, as we mentioned before briefly, there are constant flow devices. So that's a ventilator-based CPAP, as shown on the far left. That's the Babylog 8000, if some of you are familiar with it. Any kind of bubble CPAP setup would be considered a constant flow device, although we all recognize that the flow does vary a little bit because of the bubbling that's created, the pressures are varying a little bit because of the bubbling that's created. And then finally, on the right, you have a variable flow device. And the variable flow device, and the example I'm showing here is the CPAP device, where the flow varies at the level of the interface, depending on if the baby is inhaling or exhaling. And you may have certain other devices that do a similar kind of flow modulation. But having described all of these, there's no consistent evidence that any one device over another is superior in relation to clinical outcomes. And I think it's ultimately more important that you stick to one type of device, know it really well, and everybody in your unit understands that device very, very well, so that any kind of troubleshooting can be facilitated and done in a proper manner. When it comes to NIPPV, most NIPPV is ventilator-based, but there are some specific non-invasive devices. So the image shown on the left is the VN500 by Draeger, and the image shown on the right is a CNO device. It's a particular device meant to give non-invasive respiratory support. But there are very limited comparative data on the type of device when giving non-invasive positive pressure support, positive pressure ventilation. Now, there are some comparisons between synchronized and non-synchronized NIPPV, and the available data does suggest that synchronization may lead to superior outcomes, including subgroup analyses in the Cochrane review that when they limit themselves to synchronized NIPPV. This book chapter that I'm referring to here by Brett Manley and others nicely summarizes the available data on synchronized NIPPV, if anybody's more interested in looking at that in further detail. Now, the ways to synchronize NIPPV, either you can use some kind of a device that looks at the abdominal excursion. So the Graysby capsule is one example that was used with the Infant Star ventilator. And at least in North America, this device is no longer available because the company doesn't make it anymore. But this device would look at the abdominal excursion and send a signal to the ventilator that the baby is trying to take a breath, and the ventilator would then provide a peak pressure. The other way to do this is using a pneumotac or some kind of a flow sensor that's interposed between the Y piece and the nasal interface, which would attempt to detect a signal of flow into the baby as the baby is trying to take a breath in and send a signal to the ventilator. How well these work is a little bit controversial, but it really depends on the device type and which kind of pneumotac is being used. But as we have those, a new type of non-invasive support that's making many units have already adopted, and many are in the process of adopting or studying, is NIV-NAVA. So that stands for Neurally Adjusted Ventilator Assist. And NAVA, by the way, can also, of course, be provided invasively. And the basic concept with NAVA is that you have a feeding catheter that is also equipped to monitor the electrical diaphragmatic signal. So when the diaphragm receives the neural signal from the brain to contract, the catheter picks up that neural signal and sends that signal to the ventilator. So normally, as we all know, this is the pathway from the brain deciding to take a breath all the way down to the airway pressure, flow, and volume change. And normally, most devices will be using the flow and volume change, like in a pneumotachograph or other kind of flow sensor, to detect that flow change and send that signal to the ventilator. The other limitation is that that flow sensor may or may not be accurate depending on how much leak there is around the mouth and such. But that is the most common mechanism of providing synchronization. But what NAVA does it picks up the signal in the pathway that's proximal or earlier than the flow and volume change. It's the diaphragmatic excitation based on the neural signal, and it sends that signal once it picks it up to the ventilator to synchronize and provide a breath. So you can imagine that not only will this be more accurate in terms of aligning better with the baby's efforts, but it may also be more accurate in picking up that signal. If anybody who's interested, Howard Stein is a neonatologist in Ohio, in Toledo, and he does a lot of implementation of NIV-NAVA in its unit, and Kim Firestone and Howard Stein and Jennifer Beck is the University of Toronto, and her and her partner were the ones who actually first created this idea. And this is a very nice review that summarizes both the physiology mechanism and also the clinical application of NIV-NAVA in neonates. For everybody to also know, there's a DIVA trial that's ongoing from Liz Foglia at CHOP and the Neonatal Research Network group in the US, and they are studying NIV-NAVA versus NIPPV as a post-extubation form of support in babies that were 24 to 27 weeks gestation. So this study has already launched, and they are going to be looking at extubation failure over the first 5 days as their primary outcome. So many of us are eagerly awaiting the results of this trial because this will be a big step in the evidence base on NIV-NAVA versus NIPPV. In the meantime, though, the current evidence for NIV-NAVA is very, very limited. This was the last time the Cochrane review was updated in 2020. And looking at a number of different outcomes, the only outcome that there is some data for is a failure of modality. But as you can see, the numbers of participants in the only RCT that was eligible was only 16. This is very, very low evidence. So ultimately, from experimental data at the moment, there's very limited evidence to support the use of NIV-NAVA, and most of the evidence really comes from anecdotal experience, case series, observational studies. So there is a need to do more randomized trials and to generate an experimental evidence base for the use of NIV-NAVA, which will come in the next number of years. So we've touched a bit on various devices. So now we'll talk about settings. So traditionally, CPAP use in neonates has been relegated to between 5 and 8 centimeters of water. And I think if you looked at the slides I presented earlier where we showed all the settings comparing CPAP and NIPPV, you would have noticed that most studies have used somewhere in that range of 5 to 8. And I do think, like I mentioned before, that we have to exercise caution with the use of CPAP of more than 8 in the surfactant phase. And what I mean by the surfactant phase is in the period of that baby's life when the baby may, in fact, need more surfactant or the initial dose of surfactant. We're all familiar with the COIN trial, which I alluded to earlier. And I think many of us will remember that there was a higher incidence of pneumothorax in the CPAP group compared to the intubation group. And one of the speculations put forth was that could it be that the incidence of pneumothorax being higher was because babies were receiving a CPAP of 8, and many of these babies had not yet received surfactant. And based on the physiology of RDS, that this may have been part of the reason why these babies had a higher incidence of pneumothorax. And I think this is something we have to keep in mind. But having said those limitations, the optimal CPAP level, particularly for babies that are out of the surfactant phase, is really unknown. So when you are extubating a baby that's 1, 2, 3 weeks old, and if you're using CPAP or you're using CPAP at a later stage in that baby's course, what the optimal pressure is unknown. And I was part of this group where we did this Cochrane review led by Nick Bammett, who's at CHOP. And we looked at all indications of CPAP, and we concluded that there are at the moment insufficient data from randomized trials to guide CPAP level selection in preterm neonates. However, there is emerging work now to establish the optimal CPAP level as a primary mode, as well as its use post-extubation. So the optimal trial is from Europe, where they are looking at babies of gestation 26 to 29 weeks who are being allocated to receive a higher versus lower PEEP during both neonatal resuscitation and over the first 120 hours of life on non-invasive support and CPAP. The ECLAT trial has actually been published and completed, and this trial looked at babies of gestational age less than 29 weeks or 28 weeks. There were 139 infants randomized to either high CPAP or standard CPAP. So high CPAP was 10 centimeters with a range of 9 to 11, whereas standard CPAP was 7 with a range of 6 to 8 post-extubation, and they were mandated to keep those limits for the first 24 hours. What they found is that the extubation failure was much lower when using higher CPAP at 35% versus 57% when standard CPAP was used. And this was published just last November in Lancet, Child and Adolescent Health. When it comes to NIPPV, on the other hand, there are even fewer data on how to use NIPPV. Vineet Bhandari is now at Cooper Health in New Jersey, and he has published this very nice review that I just present the table for, where he suggests the initial modes depending on how NIPPV is being used, whether it's being used as a primary mode, whether it's being used as a post-extubation mode, and he provides some guidance on what PIPs, PEEPs, and rates to use, but also acknowledging that these are based on very limited evidence. It's really expert opinion, and the optimal strategy is still unknown. At McMaster, Yogesh is one of our fellows who did a systematic review on this topic, and we looked at all data that's available on preterm neonates on what kind of both pre and post-extubation studies have been studied. And I'll focus these results on post-extubation non-invasive support. And what we found is that the only mode that has been studied is CPAP. And we divided CPAP into higher versus lower. And essentially what we're showing here is for the outcome of treatment failure, there's a signal that higher CPAP is better. It leads to lower treatment failure. And also for the outcome of reintubation, there's a signal that higher CPAP may be better, although the pooled point estimate crosses 1. So this outcome does not mean statistical significance, but still, there are very limited data. In total, less than 300 babies have been studied for these comparisons overall. And this, by the way, includes the ECLAT trial that I just showed you in the previous two slides ago by the group from Australia. That's the Kidman study here. That's the largest till date. So still a lot more work needs to be done for both CPAP and other modes to identify what is the most optimal post-extubation strategy, but CPAP and other modes, pressures and settings in general. We concluded, based on this review, that the post-extubation settings that optimize extubation success and other clinical outcomes continue to warrant further research, as I stated just earlier. Finally, to keep up with the theme of how to use non-invasive support, interfaces are very, very important. And we've talked a lot about the different forms of types of non-invasive respiratory support, the different settings, different devices, but ultimately, how the interface is applied is a very important part of non-invasive respiratory support, because if the interface is not applied appropriately, the rest arguably doesn't matter. So the two types of interfaces are either prongs or masks. For prongs, the correct size prongs should snugly fit the infant's nares without pinching the septum or causing blanching. And the mask, the ideal size and depth, should prevent the mask from touching the nose tip. So always do look at whatever manufacturer's devices or products you're using and what size they recommend, because that is a very, very important aspect of preventing nasal injury. Some other general tips are that there should be very close monitoring to ensure proper positioning of non-invasive respiratory support. And I put that in red because this is arguably the single most important aspect of providing non-invasive support in preterm neonates. That interface has to be on properly. We have to ensure that there is no pressure on the septum from nasal prongs. We need to check the bridge of the nose periodically on the nasal mask. And we have to make sure that the pressures are being delivered as we have set them. We may have to suction the nasal cavities, the oropharynx, and even the stomach to ensure patency of the airway and to prevent abdominal distension. And finally, the gas delivered through the non-invasive system should always be heated and humidified to prevent injury to the nares and to avoid bleeding and dryness of the nares, especially given how high the flow rates can sometimes be. So in terms of the key messages on how to use non-invasive respiratory support, we've covered that there are a multitude of devices for both CPAP and NIPPV. There's no consistent evidence to suggest that any one mode is superior over any other. Synchronized NIPPV, including NIV-NAVA, may be superior to regular NIPPV. When we talk about CPAP, the traditional pressures are between 5 and 8, and there's very limited evidence to guide the choice of settings. But there's some emerging data that I've shown you that higher pressures on CPAP, post-extubation especially, may lower the risk of failure and may also decrease the risk of reintubation, but there needs to be more work done in this field. And I'll once again highlight that interface management at the bedside is of utmost importance and may influence the degree of pressure transmission and also ultimately how successful a particular mode of non-invasive support is. So I'll finish with some take-home points. Over this last 40 minutes or so, we have covered that non-invasive support may reduce lung injury and associated morbidity in preterm neonates. CPAP and NIPPV are the prototypical non-invasive forms that may be used as primary or post-extubation support. There are limited data on optimal settings. The role of newer modes, such as non-invasive high-frequency ventilation and NIV-NAVA, they continue to warrant further evaluation. It is my firm belief that future comparative studies, they should account for the mean airway pressures, and we should stop comparing these modes at different mean airway pressures, but rather make sure that those comparisons are at equal mean airway pressures. And there has to be meticulous interface management at the bedside with relevant education, which is the ultimate key to success. That's all for my talk. Thank you very much once again for this opportunity. I'll be very happy to take any questions, comments from the audience.
Thank you, Dr. Amit, for your very informative presentation. It was very nice. Don't know if any question. Only my question, do you have any data about for everywhere they are doing the lung ultrasound to check for the lung. Do you have any data about between the BEEP and the BIB in the CPAP or OptiFlow or the high flow between the ultrasound and the pressures?
Yeah, that's a great question, Dr. Yad. No, thanks for asking that. And this is something that I think we all know that lung ultrasound has come up in a big way to, for example, determine the need for surfactant, to determine the distinction between RDS and TTN. However, I'm not aware of any data that lung ultrasound has been used specifically to assess the optimal pressures on CPAP and other non-invasive modes. In fact, Adel Mohammed from Mount Sinai Hospital in Toronto, he's doing a lot of work along with Daniel DeLuca on lung ultrasounds. And Adel and I have talked a little bit about using lung ultrasounds as a means to determine the degree of lung inflation, because if you can do that, that may be a way to actually identify optimal pressures on non-invasive modes. But till date, at least I am not aware of any systematic study that has looked at using ultrasound as a surrogate marker for optimal pressures on any form of non-invasive support. But that's a very, very good question, because I think that we need to kind of combine and integrate the use of lung ultrasound to help identify the optimal pressures. Thank you.
Please also Dr. Hisham as a question.
Yeah, please, if you allow me.
Yes,
thank you very much for this nice review and nice presentation. I know you covered a lot of things, including the interfaces. You only mentioned the mask and the short binasal. But in the Middle East here, we are actually, a lot of units are using the RAM cannula now, especially to apply NIPPV in the neonatal ICU. Do you have, are you supporting this practice? Do you have any data about this use of RAM cannula? Do we have enough evidence to support this?
Thank you. That's a very important question. RAM cannula, the advantage of the RAM cannula is that it is very user-friendly. and it allows for a much easier application. It doesn't involve the need for a hat, and the interface itself is very, very simple. The main limitation is that the transmission of pressures can be much lower with the use of the RAM cannula, and I think that's the major limitation that the RAM cannula poses. I'm just going to show you. I'm going to apologize for this, but I'm going to quickly try to find the data on pressure transmission if I can. Yeah, here it is. So here are some data on the RAM cannula pressure transmission compared to a Draeger full interface. I'm just going to orient everybody to what this slide means. And most of our babies have their mouths open. So we can look at panel B where the mouth is open. And the x-axis shows the set pressure. So as a user, you set a certain amount of pressure. And the y-axis shows what the measured pressure is. And you can see that the gray dots represent the Draeger baby flow prompts, which are the more traditional kind of nasal prompts that I've shown you. And you can see that the pressure transmission is actually much greater with that kind of interface compared to the RAM cannula, where you can see that with an open mouth, there's a significantly more loss of pressure. And then the other factor is that if the RAM cannula occludes, or the degree to which it occludes the nares, and what happens is as you go across these, the smaller the RAM cannula gets, means that there's less and less occlusion. The greater is the drop in pressure. So that's a very important thing to keep in mind, that the same setting on a more traditional interface on CPAP or NIPPV, if you take those same settings from a traditional interface and apply that to the RAM cannula, the pressure transmitted to the airways will be significantly lower compared to the traditional interface, even if the ventilator is reading that the pressures are adequate. These are similar data that I had done during my fellowship, where we looked at this in a lung model. And you can see here on the right, what we're comparing is the set PIP on the ventilator and the measured PIP at the level of the lung using a pressure transducer. And you can see that using in both, there's a significant drop in the peak pressures in this model, but that pressure drop was significantly more with the use of RAM cannula versus a short binasal prompt. So I think it's just something we have to keep in mind. And if you are a center that's committed to the use of RAM cannula, you have to accept that the pressures that you may have to set to achieve the same transmitted pressure will have to be much higher.
We have one question, Dr. Amit. They are asking, what is the starting rate used on non-invasive PPV?
Yeah, thanks for that question. So I'll bring up this slide again by Dr. Pandari that gives some guidance on what frequencies you might use. So I'll just talk you through here. So if you're using it as a primary initial mode, you might choose a rate of 30 with a maximum support he's suggesting up to 45. Post extubation, the suggested rates, have been anywhere between 15 and 40. I will say that in my own personal practice, I prefer to leave the rate at 40 and adjust the peak pressures. But the short answer is that there's no optimal strategy that has been evidence-based and studied. I will quote Dr. Ramanathan from California, who has done some of the studies, RCTs on NIPPV versus CPAP have been done by his group. And he will also suggest that in most times in his unit also where they use NIPPV almost exclusively, they will leave the rate at 40 breaths per minute. And that's my personal practice as well. But it wouldn't be incorrect to at times decrease the rate down to 15 or 20. But anywhere between the rate of 20 to 40, I would say would be considered appropriate for NIPPV.
Thank you. Only I have last question. Do you think about for the non-invasive high frequency, it will be more in our practice in the future now,
Yeah,
or according to the benefits?
yeah, that's an important question. I think you will see that in our Cochrane review when it comes out, it is the signal that we have seen so far is that from the trials that have been done, it is being shown to be superior to some of the comparisons. And when we publish these results, we will add all the details and present all the nuances. But I think there are two unknowns. One unknown is that what if nasal high frequency was used at similar mean airway pressures at CPAP? Or in other words, if CPAP was used at similar mean airway pressures as all these studies on NI, non-invasive high frequency, have been used. So that's one thing that in my mind is a big unknown. And if I were a unit applying non-invasive high frequency, I would first ask the question, what kind of CPAPs are we comfortable with? And if we are comfortable with non-invasive high frequency using a map of 10 to 12, why would we not be comfortable on CPAP at a similar PEEP or mean airway pressure of 10 to 12? So that's one unknown. So I think before we rush to apply non-invasive frequency in our babies, we have to just keep that thing in mind. And the other part of it is that I think will take a long time for us to understand is if we're using non-invasive high frequency, especially as a primary mode, what kind of impact does it have on sleep, comfort, and long-term outcomes? Because it can lead to some degree of oscillation that's transmitted to the baby's interface and the baby's head. I'm really speculating here. I don't know the answer to this, but it's just something that I wonder about. So I think those are some of the questions that we have to ask and be really cautious about. But I think there's a significant interest, and I think more and more RCTs are going to continue to be released comparing these two modes.
Okay, thank you very much. Thank you. Okay, so no time, no more question. Thank you.
Well, thank you very much. Thank you very much for this opportunity. I appreciate it.
Thank you. Thank you. Okay, so now we will go to the next topic for the Dr. Martin. Yeah.
Yes, I'm here. Sincere apologies about the glitch. For some reason, it would not let me sign in.
Okay, thank you. So we'll start again with our presentation will be about the novel neonatal ventilation strategies. Dr. Kessler Martin, he graduated from McGill University Medical School in Montreal, Canada. He's a professor of pediatrics at Brown University and remains clinically active at Women and Infant Hospital of Rhode Island. Dr. Kessler, he was and is still an active member for the Neonatal Research Network, and his interesting area and research area with the volume and target ventilation, delivery room stabilization, and high frequency ventilation, pulmonary hypertension, pulmonary dysplasia, and NO. Welcome, Dr. Martin.
Thank you very much, and thank you for the opportunity to share with your viewers. Let me see. Some thoughts about novel therapeutic interventions in neonates. Hopefully this will open up. Good. Can everyone see my screen?
Yes, yes.
Okay. So I have limited time and a lot of ground to cover. So I will, in some instances, only scratch the surface, and I will talk about not only things that work, but actually more often than not things that I don't think actually works, because new is not always better. Often it is, but not always. So I will just mention that I have had some honoraria and research funding in the past from Draeger. Nothing current and directly relevant. I will mention study of high-frequency ventilation with the Draeger device.
Dr.
Moving
Kessler,
on.
if you may allow me, can you make your slides full screen, please?
They are on my. They are full screen on my monitor. That's interesting. Let me try that again.
F5. Can you check by F5?
Yeah, let me try that again.
F5 or no?
If not possible, just go ahead, please.
Okay, let me just see. F5 didn't do anything, but I'm on a Mac, which may be impacting this. Let me see if I can stop share and reshare. Whoops. This may be. Goodness. Now I've lost things altogether. That's not good. Okay, hold on. Okay. Share screen. Is that better?
Go ahead, yeah.
It's the same, but we can go ahead. Yeah.
Huh. Okay, it's
yeah, now it's yeah. Oh.
It is full screen on my computer. I don't know. I unshared, reshared, still nothing. All right, let's just go ahead if we must. So I want to start off with pointing out that, of course, what we're all trying to do is prevent lung injury, and that process is very much multifactorial, often beginning already in utero with chorioamnionitis, severe growth restriction that affects fetal lung development, that has further implications down the road. A lot of important things happen around the time of birth with initiation of air breathing, potentially positive pressure ventilation and such. Without going into the detail, the message here is that because it is so multifactorial, no single intervention is likely to make a dramatic impact. So we need to do our best to do everything right as best as we can. And so, of course, one of the key things that we deal with is the newborn's inability to rapidly establish and maintain functional residual capacity at birth and subsequently for all the reasons listed there. And one of the things that was of great interest for a few years recently was the use of sustained inflation. Harish Kirpalani and I and Peter Davis did a large randomized multi-center trial, which unfortunately did not support the use of that intervention. And in fact, now it's not advancing. Oh, there we go. And in fact, it resulted in some increased short-term mortality. The overall mortality was not higher, but looking at a meta-analysis of all these studies that have looked at sustained inflation, the point estimate favors not doing sustained inflation. It's not a statistically significant difference because the confidence interval does just cross zero, but sustained inflation does not appear to be the correct answer in the extremely immature infants. It may be less of an issue. There seem to be less harm in the larger ones. But as you just heard in the elegant lecture by my friend Amit Mukherjee, the best way to avoid injuring the lungs is to use non-invasive support. And I will just briefly touch on a few issues regarding non-invasive support from my perspective. So Amit spent a fair amount of time discussing the question as to whether NIPV is better than CPAP. NIPV has taken the world by storm, advocated by Vineet and Bandari and Ram, Dr. Ram, who are great advocates, but as you saw, some of the evidence does not necessarily support that. It does, in fact, NIPV and IPPV does, in fact, work, but not the way people think it does. It does not actually ventilate, contrary to popular opinion. It does not generate a tidal volume, but it is a stealth way of increasing mean airway pressure, as you just heard. And I think the evidence strongly suggests that the benefit of NIPPV is mediated by higher mean airway pressure. Why is my, oh, I see, huh. It is, all right, let me try this. All right. So here is a graphic from a paper by Louis Owen, who showed many years ago that even using short binasal prongs, when the baby becomes apneic, NIPV, which is cycling up here, generating positive pressure, does not result in any abdominal wall movement measured by Graysby capsule or by respiratory inductive plethysmography, and the baby's saturations begin to drop. This is by and large, apparently because of the fact that very few pressure cycles actually coincide with the baby's spontaneous inspiration, and the fact that in premature infants, when the baby is not breathing, the glottis tends to be closed, and therefore the gas does not actually get to the baby. For some reason that slide that shows that only a small proportion of cycles actually generated at tidal volume. So what about synchronized NIPPV? There is some suggestion that it results in a little bit better support, but there is a problem with that as well. So here is a modality that's basically CPAP with apnea backup ventilation. So here the ventilator cycling, providing NIPV, baby's breathing, therefore triggering, then the baby becomes apneic. And because it's not triggering, there's nothing goes on, then the apnea backup ventilation kicks in. The ventilator cycles are initiated again, but there is still no chest wall movement. So the same problem seems to apply even with synchronized NIPPV. And it is, in fact, a reality that when you look at the baby who is on NIPV, the chest wall does not move when the ventilator cycles, at least large majority of the time. A more recent study from Arkansas looked at NIPPV delivered via RAM cannula, which I totally agree with Amit, by the way, that RAM cannula is not a good interface. It does not actually transmit pressure at all effectively, and we abandoned it a few years ago. You can't do bubble CPAP through a RAM cannula either, and there is some evidence that bubble CPAP actually works better than regular CPAP. So back to what this study shows, which is basically when the baby breathes by themselves, there is a certain displacement of the chest wall by respiratory inductive plethysmography. When the patient and ventilator, and this was unsynchronized, happen to coincide, there is no appreciable difference in terms of an increase in tidal volume delivery. And when the ventilator fires by itself without a baby effort, there is very, very little tidal volume generation. So by and large, there's little evidence that NIPV actually ventilates the patient, but it definitely does increase the mean airway pressure. And I think Amit alluded to these two studies, which both show that the higher end expiratory pressure in green resulted in lower rate of failure criteria being met, reintubation by 96 hours or reintubation by 7 days. And then this was comparing 4 to 6 versus 7 to 9. The Australians were even more courageous when it comes to CPAP, and this was again a post-extubation study that looked at 138 preemies, pretty small babies, mean gestational age just under 26 weeks, who were extubated at approximately 4 days of life. And again, overall, there was a much lower risk of needing intubation reintubation by 7 days. That was less dramatic in the very mature babies, not surprisingly, but quite dramatic in the 26 and 27 weeks. So higher distending pressure is more effective, and NIPV does facilitate the use of higher mean airway pressure for those who are not comfortable with increasing the level of CPAP beyond the traditional maximum of 8. And by the way, the idea that the CPAP of 8 was responsible for the increased rate of pneumothorax in the COIN trial, as was mentioned previously, is probably not because the CPAP of 8 was too much. Those babies, by definition, in the COIN trial that were on CPAP of 8 had not received surfactant. Those babies that developed pneumothorax were developing pneumothorax on days 2 or 3 for the most part, and had a rising oxygen requirement. And the difference between the COIN trial and all the other CPAP versus immediate intubation and surfactant, the other important difference was that the failure criteria for that COIN trial were FiO2 of 60%. As opposed to 40% in the other trials, meaning that those babies were struggling with a considerable amount of atelectasis, and that is where you get pneumothoraces. And we'll get back to that theme in a minute. So higher distending pressure is more effective, and NIPV is good at providing a higher mean airway pressure. So that is those are the facts. That's my view then, therefore. And so if you ask me what rate of NIPV I use, it's 0. And when I come on service, some babies on NIPV, I pretty rapidly wean the rate, and always matching the mean airway pressure by increasing the CPAP level as I wean the rate. And within 24 hours, the baby is on CPAP on the same mean airway pressure, and the baby never notices. Another way, a stealth way of increasing mean airway pressure, is a modality that's not really been studied in neonates. It's airway pressure release ventilation, or APRV, which is a strange, it's sort of a high CPAP with brief releases. So there's basically a high pressure, low pressure. Inspiratory time is very long for the higher pressure, and there's brief release of that pressure to baseline, and then back to the higher level of CPAP. They don't really call it CPAP, they call it airway pressure release ventilation. So yeah, essentially is another way of increasing distending pressure. And again, it's not been studied in neonates. There is a paper in a few years ago that looked at infants and young children, and actually showed higher mortality in the airway pressure release mode. So it's not really been embraced by neonatologists. But because the rate here is very low, it depends also on spontaneous breathing. So if the baby does not have good enough spontaneous respiratory effort, again, it's not going to work. So I'm spending a lot of time talking about things that don't work because, of course, we are neonatologists. We're enthusiastic about new technologies. We like to try something new, and sometimes it's not to our patients' greatest advantage. So let's talk about NAVA, and in this case, I'm going to focus on invasive or intubated NAVA because I am a fan of non-invasive NAVA. It's a great way to trigger and synchronize non-invasive support. It's really the best way to do so, but when it's applied to an intubated baby, I have some concerns. So as you heard previously, basically you measure the electrical activity of the diaphragm by a specialized catheter, which by the way is pretty expensive. And that that signal is multiplied by whatever level you choose, and it determines the pressure delivery by the ventilator. It is a positive feedback mechanism, meaning that if the patient's effort is very limited, there will be less pressure, and when baby breathes vigorously, it will deliver higher pressure, assumes mature respiratory control. In Europe, there is also a modality that's a similar principle in terms of positive feedback, although it's modulated differently. The proportional assist ventilation on the Stefan ventilator is also a positive feedback, so the same pattern would apply. I want to contrast that with volume guarantee, which we'll talk about a little bit later, which does the opposite. Volume guarantee was designed for premature infants with irregular and immature respiratory control. So when the baby doesn't breathe much or doesn't breathe at all, the ventilator generates more pressure. When the baby generates vigorous inspiratory effort, as they do when the baby is stimulated or handled, the machine backs off quickly to avoid excessively large tidal volumes. And so, unfortunately, preemies do not have a mature respiratory control. They tend to have a lot of periodic breathing and sometimes vigorous bursts of respiratory activity. So applying positive pressure in an intubated baby that is in proportion to their respiratory effort would actually amplify these fluctuations and probably is not a great idea. So again, contrast it to the adult who has relatively consistent respiratory effort because of the maturity of their respiratory control system, contrasted to the baby who sometimes generates dangerously high inspiratory effort when handled, when stimulated. Again, the proponents of NAVA are very proud of how tightly the pressure generated by the ventilator tracks the patient's respiratory effort. But I ask you, do you think that's actually a great idea? Here the baby's not breathing much, doesn't get much help. For a while breathes appropriately and reasonable pressures around 20. Then there's another period of hypoventilation with limited support in proportion here. And here maybe somebody banged the incubator or spoke too loudly or God forbid touched the baby, and there's a burst of very strong inspiratory effort resulting in peak pressure of almost 40 centimeters. So this is probably not something that I would want to apply to my patient. With non-invasive NAVA being an open system, you probably never transmit really high pressures. But with intubated patient, this could potentially be dangerous. There is a study that actually looked at the proportion of tidal volumes that were greater than 10 ml per kilo. And you can see the horizontal axis are different degrees of support, NAVA level. Oops, I'm sorry, I don't know why it went back. The NAVA level, basically at the moderate and NAVA levels, more than 20 and sometimes many more than 20% of tidal volumes exceeded what I think we would all agree is potentially dangerous tidal volumes. There are no randomized trials of NAVA in newborns with meaningful outcomes. There's a bunch of small crossover studies that show that maybe pressure is lower, the oxygen is lower, something is lower, but no important outcomes have been demonstrated with the use of intubated NAVA. But it has been vigorously promoted by people with potentially some conflicts, and I would caution you not to get carried away with intubated NAVA. Let's talk about something that does work. Of course, I'm an enthusiast for volume targeted ventilation, but that's based on some reasonably solid data. This is the most recent Cochrane, which many of you are familiar with, showing that BPD at 36 weeks post-menstrual age was reduced by more than 25%. The confidence intervals do not cross 1. So this is a significant result with a number needed to treat of 8. The combined death and BPD just missed significance. The other outcomes, severe intraventricular hemorrhage, periventricular leukomalacia, or severe IVH, pneumothorax, all the things you would expect to be less frequent when you avoid excessively large tidal volumes, indeed have that effect with roughly 50% reduction. And these are the confidence intervals, again, not crossing 1, number needed to treat listed here. Hypocapnia, similar 50% reduction, but because hypocapnia is common, number needed to treat is only 3, and shorter duration of mechanical ventilation. And this meta-analysis included about 20 studies with almost 1,000 infants, So we don't have that one large randomized trial. These are a bunch of smaller studies, and that's a limitation. But there is certainly reason to believe that avoiding excessively large tidal volumes is a good thing. I want to draw the contrast between volume-controlled ventilation that's used in the pediatric and adult intensive care units and volume-targeted ventilation. They're not the same, although the literature is sometimes confused about that point. And the problem with volume-controlled ventilation on devices like the Servo, Servo I in particular, and this newer Servo N is a little bit better in this instance, but basically what's controlled with volume-controlled ventilation is the volume of gas that's injected into the proximal end of the ventilator circuit. And there will always be a loss of volume to compression within the tubing and humidifier, some stretching of the circuit. But when there's a large subject or large patient with large lungs attached here, this is not a real problem, and it can be compensated by an algorithm, the compliance compensation algorithm. However, when you attach a very small baby over here, less than a kilo, and who is intubated with an uncuffed endotracheal tube with variable leak around the endotracheal tube, this system breaks down and accurate tidal volume measurement is not possible. And that's why many years ago, when some of us were starting in the field and tried using volume control ventilation, we converted to pressure limited ventilation as the standard modality. So the basic approach to volume targeted ventilation is and again, the distinction is that volume targeted ventilation, things like volume guarantee, are actually pressure controlled ventilation with continuous real-time adjustment of inflation pressure. So there is a pressure that's generated. The tidal volume that results from that is measured and is compared to the target tidal volume. Oh, come back. What's happening? I think the pointer advances it compared to the target tidal volume. And then depending whether that tidal volume that's measured is less than, equal to, or greater than the target, the inflation pressure will be adjusted upward, kept the same, or reduced for the next cycle. And then this all feedbacks again, generates a new tidal volume, and the cycle repeats. So that's the basic way this works. And of course, there are no pretty good data to support the idea that it does, and we showed this many years ago, maintain a relatively constant tidal volume. The baby is always perturbing the equilibrium by their variable respiratory effort, so it's not completely constant, but on average, it gives you exactly what you asked for. But importantly, it prevents overdistension, volutrauma, and hypocapnia, when all the things that happen soon after birth or soon after intubation happen, like being given surfactant, optimizing lung volume, which improves compliance, and baby clearing their lung fluid. All of these things might be happening soon after we do some of these things, and now we're busy putting in lines, and things can get out of hand. The other thing, of course, that's important is that the ventilator does not wait for the next blood gas. It does not wait for morning rounds to make a decision. It weans in real time and results in more rapid weaning, as we saw from the meta-analysis. And it compensates for that highly variable respiratory drive, that periodic breathing that we also saw. So most of you are probably familiar with it. I'm not going to spend a lot of time because volume targeted ventilation is not terribly novel, but it does work. And what may be novel for some is that one size does not fit all. While tidal volume of 4 to 5 ml during the acute phase of RDS works for most average-sized premature babies of, say, 750, 800 grams and above, really tiny babies need a larger tidal volume. Infants with a high alveolar dead space, where there's a lot of wasted ventilation, and older infants with chronic lung disease, where there's also a lot of alveolar dead space or wasted ventilation, they all need a larger tidal volume. So one size does not fit all, And it's important to know what the appropriate initial tidal volume is, and then we adjust based on the baby's response. It is better to use it with assist control, where every breath is supported, and we need to pay attention to not just the actual pressure, but the pressure limit rather, but the actual pressure. Now, I want to just briefly spend a moment to talk about the importance of an open lung strategy. In other words, making sure that the tidal volume that we're delivering is evenly distributed throughout the lung. And I will hopefully have convinced you before, or will convince you now, that that's important. So here we have a chest radiograph of a baby with severe RDS. And we think of RDS as a homogeneous disease, but in fact, if you cut the lung across with a CT scan or MRI, this is actually a sheep, not a baby, you will see that much of the atelectasis is concentrated in the dependent posterior portion of the lung, with aerated lung anteriorly. And there's lots of bad things that are happening. There is increased surfactant turnover here in the atelectatic area. There's shear forces at the boundary between aerated and unaerated lung. But probably most important is the regional volutrauma, the fact that majority of the tidal volume that will enter these lungs is going to enter the anterior, non-dependent, aerated portion of the lung. And this has to do with Laplace's law, which you all remember from medical school, which tells us that the pressure needed to distend an alveolus or a balloon or any other spherical structure is inversely proportional to the radius. So the critical opening pressure of these atelectatic alveoli is much higher than the pressure needed to overdistend what's already aerated. And therefore, you have regional volutrauma here, even when you are controlling tidal volume delivery very nicely. And there's actually experimental evidence to support this. This has been around for a long time. The evidence, that is, looking at histological scores, hyaline membrane score, well, that may not be the most important thing, but again, it was mostly in the non-dependent portion of the lung. These were lavaged animals, ventilated with the injurious modality was basically your low PEEP and high peak inflation pressure. Looking at overall composite score, again, the non-dependent portion of the lung had the greatest degree of injury. Looking at inflammatory markers and cytokines and mediators of lung injury, again, the non-dependent portion of the lung bore the brunt of the lung injury. So having an open lung reduced, non-injurious equal open lung. And so distributing tidal volume evenly is really important. So we need to know how to recruit the lung. Many of you are familiar with the concept, right? Now we are going to look at the overall lung hysteresis, the overall lung pressure volume relationship. And if we have a lot of atelectasis at the beginning here, we have poor lung compliance. We're on the inspiratory limb of the pressure volume relationship. We have poor lung compliance, as evident by the slope of this line. We have poor oxygenation because we have a lot of ventilation perfusion mismatch and high oxygen requirements. So what we need to do is gradually increase that mean airway pressure, whether we're doing it on an oscillator, directly increasing mean airway pressure, or with conventional ventilation, increasing end expiratory pressure. We need to stepwise increase it using oxygenation as a guide until we have reached an open lung where FiO2 has been able to be weaned typically below 30%. The Dutch like to go less than 25%. But now we have got to the point where there is some regional overexpansion because there are differences in compliance between different portions of the lung. And so we don't want to stay here because this would cause hemodynamic impairment and an overexpansion of lung injury. We need to slide down the expiratory limb to find the sweet spot just above the critical closing pressure. Why is this true? Well, once you aerate the lung, once you open the alveoli, Laplace's law tells us that the lung now has become more compliant, and the pressure that was needed to pry open the atelectatic alveoli is now excessive for the open alveoli, resulting in overexpansion. So that's why we need to come down on the distending pressure once we've opened up the lung. And now we can actually visualize with electrical impedance tomography how the distribution of aeration shifts as we progressively increase the mean airway pressure. So there was a lot of discussion about PEEP and about what levels of distending pressure are important. And indeed, this is the thing, right? We know that with healthy lungs, this is looking at scanning electron microscope, looking at subpleural alveoli. You can see that throughout the cycle, both inspiration and expiration, the alveoli are remaining open. In an injured or surfactant deficient lung, alveoli tend to collapse at the end of exhalation. And this leads to either generalized atelectasis or the recruitment, de-recruitment for kind of lung injury. One way to get around that, of course, is oscillatory ventilation, where the bottom of the pressure waveform remains above the critical closing pressure, and therefore alveolar stability can be maintained. But the same thing can be achieved with using adequate end expiratory pressure with conventional ventilation, preferably using relatively small tidal volumes. And we've known this for a very long time, that PEEP is protective. This is just looking at physical static pressure volume loops, and with zero PEEP, you can see after a brief period of ventilation, the loop is grossly distorted, loss of hysteresis, and all kinds of badness. And when you finally increase the PEEP to an optimal level, about the lower inflection point, the lung injury is significantly mitigated. But throughout the world, PEEPophobia persists. Fighting PEEPophobia has been one of my goals in life, and I've been only partially successful. There is no magic PEEP. More is not always better, and so it has to be a dynamic determination. It has to be individualized to the patient and their particular pulmonary status. The goal, of course, is to optimize lung volume. And if we're starting with a lot of atelectasis, you need a critical opening pressure. You need a higher end expiratory pressure to maintain lung volume recruitment. So oxygenation is a good index of ventilation perfusion matching and by proxy of lung volume. Again, nowadays we have other tools like electrical impedance tomography. But PEEP should not be just a one-way street going up. We should also be able and willing to go down as needed. In some situations, like very large, older babies with severe established BPD, they need a much higher end expiratory pressure. And even, as you saw, preemies with RDS may need a significantly higher distending pressure and expiratory pressure than we're accustomed to. This is a survey study by Nick Bamat, who a few years ago asked people, what is the usual mean PEEP and how high will you ever go? And my friends in Canada in this study were the most courageous, not very, I mean, the mean is still less than 6 starting, so around this, and just a little bit above. They did not ask the Australians, who, as you saw from the study that both Amit and I showed you, use substantially higher end expiratory pressure. The Europeans are the most PEEPophobic, but I don't know if this is representative of all of your practices, but it is very low distending pressure, which to me would be very concerning. I think that European trial, the Optimize or whatever it was called, is a terrible idea, and I will bet pretty good money on the fact that the 3 to 5 PEEP is inadequate, at least as the initial level of distending pressure. Of course, surfactant changes the scenario, so we will see how that comes out. But again, PEEP has to be dynamic. It's not that more is always better, but it's better to start high and wean as the lungs are adequately recruited, as evidenced by low FiO2. Atelectasis is easier to prevent than it is to reverse because of Laplace's law. So I would argue that we should start on a higher end and wean if the baby allows us to. Finally, I want to finish up with what I think truly is a novel approach, which, although not terribly novel, but it hasn't taken off completely, I hope, you are using it. This is something that we did. This is a study called the Drager Ventilator Evaluation, DOVE, to try to get this device approved by the Food and Drug Administration in the United States, because we do not have access to it. All of you probably do, at least, I don't know if everybody on the call, but pretty much everywhere outside of the United States have this modality available. So we did this study to try to get folks to be able to use it for our babies. And this was a single-arm study with recent historical controls prospectively collected, because that was the deal that was struck with the FDA. Whoops, sorry. So 23 to 30 weeks, 400 to 1,200 grams, less than equal 4 days. And of course, baby needed positive pressure ventilation, and the clinical team felt that the baby would benefit from high-frequency ventilation. And here we have some results. So it was 225 babies in the prospective study and a little over 200 in the comparison cohort, collected a few years earlier prospectively. And you can see that the birth weight was similar, slightly lower here, but not significant. The gestational age mean was very similar, but there was a greater proportion of the very immature babies, twice as many 23-weekers, where the rate of complications tend to go up dramatically. No other differences in male gender, cesarean delivery, antenatal steroids, etc. And as far as the results, while this was actually designed as a non-inferiority trial, the primary outcome of being alive and free of severe intraventricular hemorrhage or periventricular leukomalacia was achieved in 83% of the subjects. There was a handful of babies where the investigators failed to obtain the late ultrasound around 28 days, so we did not have a portion of the primary outcome. So that's why the denominator is only 220, but 83%. Relative risk 0.63 with these confidence intervals. Mortality was similar. Minor grades of intraventricular hemorrhage fell short of reaching significance. Severe IVH was numerically, the point estimate certainly was substantially lower, but just missed significance by crossing line of unity here, as did periventricular leukomalacia. So individually, these failed to cross to reach statistical significance, but as the combined outcome, they did. There was less pneumothorax, statistically significant. For some reason, retinopathy appeared to be slightly higher. That may be an ascertainment bias, because in retrospective data collection, things can be missed, so we don't know for sure. And importantly, the tidal volume that we use, and we chose to use a frequency of 10 hertz. If I did it again now, I would probably use 15 hertz. And so the tidal volume that we saw was around 2 ml per kilo. If you use 15 hertz, it would be slightly lower, but it was, as you can see, very stable. These standard deviations are between patient differences, not within a patient. And the CO2, so this was at baseline, and initially a slight decrease from to about 45. We aimed in mild permissive hypercapnia, so we gradually allowed CO2 to rise back up to around 50 by 72 hours. But you can see CO2 was very stable, tidal volume was very stable. And importantly, the measured tidal volume compared to the set tidal volume was within plus or minus 0.1 ml per kilo overall. And in a subset of babies, the tidal volume was more than 0.1 ml below, because the clinicians failed to adjust the pressure and the amplitude limit. So not allowing the ventilator to do what it was trying to do. When you took out that small proportion, it was even, closer to 96%. So this device clearly did work very well, because it was managed by the bedside team who had no prior experience with the device. So despite that, there were no significant issues, no safety concerns. And this has been available to many of you for quite some time, and we now have data from the United States. So we're hoping this will this novel technology, not so novel for you perhaps, will make it possible to use high-frequency ventilation more often as a primary mode, because we no longer have to worry about inadvertent overventilation. So first-line therapy might be the answer. And that's all I have in this whirlwind, and I'll be happy to take questions. And I apologize for the technical glitches.
Thank you, Dr. Martin, for the very, very nice presentation. So we have, I think, 2 or 3 questions, but it's only, I will start with my question. So it's meaning you advise for all the babies, it is extreme premature babies, it's between the 23 or 28 weekers who need for non-invasive, invasive ventilation to put on high frequency in the first 4 days.
Well, so this has been a practice in, so for the extremely preterm babies, the 22 and 23 week, there is a strong trend now to use high frequency. And many centers use the jet ventilator for this, which is not available widely outside of the United States and Canada. I think, you know, my message more often than not is it's not what you do, it's how well you do it. And there's a nice paper that compared excellent outcomes in 22 and 23 week babies in 3 different centers around the world. One was in the US, one in Japan, one in Sweden. One used the jet ventilator, one used the oscillator, one used conventional ventilation with volume guarantee, and they all had excellent results because that's what they do, and they do it well. And they have a carefully followed protocol. So there is no, you know, the tools are important, but even more important is knowing how to use that tool optimally and safely. So with volume targeted high frequency ventilation, I would feel much more comfortable recommending high frequency oscillatory ventilation with volume guarantee as a first line approach, because the greatest risk of using oscillatory ventilation, I think, has been the ease with which it overventilates due to the geometric relationship between tidal volume and CO2, right? It's tidal volume squared is in the factor. So, so yes, I would probably recommend that now for those of you who have that that availability of those tools. And there are a number of different ventilators. The Draeger is not the only one that has HFOV with volume targeting.
Thank you. We have one question. On case of the VG, if the baby is generating tidal volume more than the set VG, even 6 ml per kg, so pressure will go down till the baby will be taking ETC PAP. So if the baby is not for extubation, is it okay to remove the VG and keep baby on BIP of 4 to 6 to overcome the ETT resistance?
So if the baby is breathing and generating a tidal volume greater than the set value as you described, you have 2 options basically. One is to well, it depends on your assessment of the baby, right? So if the baby is comfortable, is not too tachypnic, not retracting, does not have a high oxygen requirement, then I would extubate that baby. If the baby, on the other hand, is tachypnic and is retracting and perhaps has a rising oxygen requirement, that baby is asking for more support. The numbers we kick around, 6 ml per kilo, there's nothing magical about 6 ml per kilo. Some babies need more. The study that we did, published a number of years ago, that you know, looked at over time, babies less than 800 grams, as they got older, progressively needed slightly higher tidal volume. By 3 weeks, it was a mean of just over 6 per kilo, but there was a fairly large standard deviation around that. So it really is a clinical judgment. If the baby is ready for extubation based on your clinical assessment, and the best scenario is to go ahead and extubate. assuming that you have reasonably consistent respiratory effort. Keeping the baby, taking off of EG and just providing pressure support, you could do that, but I don't see the benefit, because if all we're doing is overcoming the resistance of the endotracheal tube, why not get rid of the endotracheal tube? That would be my take on that.
Thank you. We have the last question. How to work out the open lung strategy of conventional ventilation?
Okay, well, that's a great question. So there are nice published guidelines from the Dutch group about how to do it with oscillatory ventilation. And you can do very much the same thing by stepwise increases in PEEP. The only study that has actually looked at this with conventional ventilation was from Italy by Gianluca Lista's group, where they showed that stepwise increases, and I think they used quite small increments of 0.5 centimeters of water, achieved much the same thing. Again, most babies that, if we give them surfactant first, don't need aggressive lung volume recruitment. The Dutch study that showed how to do lung volume recruitment with the oscillator, they recruit the lung first, then give surfactant. So they're ending up using much higher mean airway pressures. They do this because there is some evidence that surfactant distribution is more even when you open the lung first. But I just want to caution people not to assume that after you've given surfactant, you need to go up to 20 centimeters of mean airway pressure on the oscillator to get the lung open, because nowadays most babies with the good surfactants we have now available, most preemies, if you give them surfactant, will pretty quickly wean to room air, and you don't need to do a whole lot of recruiting. But if there is an oxygen requirement still present and the X-ray suggests the lung volume is suboptimal, just increase mean airway pressure by increasing the end expiratory pressure with the conventional ventilation. Let the baby breathe on their own, because you do need a critical opening pressure as well. You need some PIP. The Italians did this by keeping the baby on volume guarantee. So as the PEEP went up, the PIP went up as well. And that gave them the critical opening pressure that was needed. And they only ended up going up about 2 centimeters on the PEEP to achieve full recruitment.
Okay, thank you. Dr. Hisham also has question. Dr. Hisham? He raised his hand. Dr. Hisham?
Yeah, I have actually a very simple question regarding the use of the high frequency as a mode of non-invasive ventilation, as it is now becoming more commonly used. What's the interface you use with it, please?
Non-invasive high frequency?
Yeah.
What?
The short binasal?
Yeah,
Which interface?
So we haven't used it much clinically, but you absolutely would not be able to do this through a ram cannula that would completely dissipate the oscillations because of the long segment of narrow tubing between the ventilator connector and the babies and the prongs. So short binasal prongs or mask would be a reasonable interface. I'm not convinced that high frequency nasal high frequency ventilation does much more than bubble CPAP, which is a cheap way of generating oscillations that are transmitted to the baby. And there are ways to make bubble CPAP provide bigger bubbles and probably does the same thing. So I'm on board with Amit's concept of let's use the least expensive technology that gives us the results, because in less resourced places, it's a lot easier to use bubble CPAP than high frequency nasal ventilation. But if we were to use it, you would definitely want to use it at a low frequency, relatively low frequency, high amplitude, because a lot of the oscillations are dissipated across the interface. Even the short binasal prongs in small babies do have pretty high resistance. So you have to allow for that. And there is, I have some concern that there may be some actual air trapping with the non-invasive. So the distal pressures may actually be significantly higher. So again, it has to be titrated. The data are inconclusive as to whether there is an advantage to it or not, but I know it's one of those things that seems attractive, and a lot of people are reaching for those things, and that's why I was kind of being a little bit, suggesting some caution in embracing the newest technologies until we have definitive data about safety and efficacy, but yes, it would be short binasal prongs, the largest size that comfortably fits, not a ram cannula.
Oh, thank you. Okay, I think here in the panel also we don't have
We're probably out of
more
time.
question.
No.
Okay, so now I
Enough,
will
because we are
give
behind
to
in the
Dr.
time.
Hisham. Okay, thank you.
Thank
So
you.
before I our next speaker, I'd like to first thank Dr. Iyad Saada for chairing this event with us. Thank you very much, Dr. Iyad, and inshallah, hopefully we'll see you in our next events. Again, also big thanks for Dr. Kessler. It's an honor actually that he participated in this event with a great presentation and updated knowledge. Thank you very much, Dr. Martin. And hopefully we'll see you for, inshallah, next time in our physical conference.
Thank you.
And now I will introduce our next speaker, and we will have, again, a change in our schedule because Dr. Robin Alvero having a problem reaching us, so he had to record his lecture, and we will do it at the end. So now it's my privilege to present our next speaker, Dr. Julian Eason. And actually, I would have the honor to work with Dr. Eason at Cornish Hospital in Abu Dhabi a few years ago. And unfortunately, he had to leave to go back to UK, and it was our loss for our unit. Dr. Julian Eason is a consultant neonatologist and a senior lecturer currently practicing part-time in the UK as intensive and transport consultant for the transport service in south west of England. Dr. Julian Eason has probably his touring the whole world practicing neonatology. So he has recently retired as a senior lecturer in aviation and transport medicine for the University of Otago in New Zealand, and he's currently one of the organizer for the neonatal training in Hanoi, also in Vietnam. He also works for the Capital Air, repatriating infants back to UK. Dr. Julian Eason trained in London and did fellowship in Canada, and his interest in neonatology mainly in transport, ventilation, resuscitation, nutrition, and neuroprotection, among other areas of interest. As I said, he has some experience in Vietnam for transport, and he worked in some part in his life in Cornish Hospital in Abu Dhabi. So without further delay, actually, of course, he has other activities in different areas of the world, but without further delay, Dr. Julian Eason today will talk to us about the European consensus guideline of RDS. What's the update? Thank you, Dr. Julian, for joining us today.
Thanks very much, Hisham, and thanks very much for the invitation. I will start sharing my screen and hopefully get my desktop onto you. See if you are able to see this. That would be great. So I'm assuming you can all hear me?
Yeah, we can see and we can hear you.
Fantastic. Okay. So as I said before, it's very nice to be invited. It's great to see my colleague Hisham again. Very nice to talk to you. I had a great 5 years with you in Abu Dhabi. I'm back now in England, dare I say sunny England, as I'm trying to shield my eyes from the sun in the evening sun which is very unusual. So delighted to talk to you today. Obviously, I'm not a primary researcher myself. I call myself a jobbing neonatologist, and I currently work part-time now in the University Hospital in Plymouth, and I work for Capital Air Ambulance, as Hisham said, repatriating sick infants from all over the world back to the UK for further treatments, and also visit a number of other countries where I'm helping with some teaching. So enough of me. I'm talking about the European RDS guideline and changes over the years. And what have we learned? Well, why am I talking about this? Well, you've heard two very great talks, and obviously, what a shame Dr. Alvaro is going to be a bit delayed, but obviously you'll hear his later on, about how to look after some very difficult infants that we see. What I'm really going to talk about with the European RDS guidelines is what we do pretty much immediately at birth, where I think a lot of harm can potentially be done. And I'm going to take you through what I think was a pretty interesting journey that we've all had over the years of resuscitating infants, and how we are trying to help and treat infants with respiratory distress syndrome. So why is this important? Well, I think really because of what happens at the end, and when our infants go home, we're trying to prevent neonatal chronic lung disease, and this is really still one of the major complications in mechanically and ventilated premature infants, and the incidence remains high. And you probably realize, and I certainly realize working in various countries, that there are massive institutional variations. Lots of different criteria for defining chronic lung disease. I think it's all done a little bit difficult and sometimes can be a little bit confusing. But essentially, chronic lung disease is a label that's quite important. And I think when you look at the long-term sequelae, and this is just a summary slide of multiple papers about potential problems with babies who have chronic lung disease, their growth failure, their repeated hospital admissions with respiratory tract infections and wheezes, their poor function, which you can now roughly correlate with CT scan, increased airway responsiveness, poor tolerance, cardiovascular issues, neurodevelopmental concerns, and quite obviously increased mortality. Now, when you look at the direct cause of chronic lung disease and its immediate impact or the actual impact on all these long-term sequelae, it's quite hard to define because there are so many confounders. And in fact, some papers would argue there's very little evidence for some of those things that I've just shown you in the list there. But I think ordinarily we do have a concern that a lot of the infants who are leaving our nurseries are going on to longer-term problems. And how can we best reduce this mortality and morbidity? Well, I think at birth, we obviously have this interesting transition to extrauterine life. And quite clearly, as we've resuscitated smaller and smaller infants, and in fact, you know, in many countries, 21, 22 weekers seem to be the norm now. We are dealing with some very sick infants who need a lot of respiratory support. They will all have had variable antenatal exposures. They will all be subjected to variable postnatal exposures. And are we getting it right? Are we doing the right thing to help these babies at their transition? Obviously, we're going from this water cell interface to the air cell interface, and hopefully one day with a normal respiratory pattern, although the evidence would show that that's not quite what happens in some of our infants when we see them during follow-up. There are lots of areas to target. I'm going to talk about some of them. We could be here for hours and hours talking about various antenatal treatments, thermal controls, types of trauma that we can cause, mechanical, oxygen toxicity, what you'll hear from a little bit later on, infection, inflammation, growth, the use of caffeine. There are many, many areas that we can target fairly early on. And the European consensus guidelines on the management of RDS have, I think, helped us over the years to develop a plan. But it has changed. And having practiced neonatology for, I guess, over 30 years, I've certainly, like many of you, will have seen some huge changes. And realizing that perhaps some of the things we did in the past were actually causing harm. And maybe some of the things we're doing now without realizing are causing harm as well. Just to say, the evidence goes back, these guidelines started in 2006, 2007. And you might be familiar with this grade of recommendations when they come out with a consensus statement. And from 2006 to 2010, we had this ABCD, fairly simple design modified guidelines, where A was right at the top with one high quality meta-analysis or RCT, and D really evidence from case series, case reports, or expert opinion. So a bit of a grade. It did get more complicated in 2013, where we certainly had the ABCD, but the levels of evidence were really quite complex. And so a little bit, I think perhaps a little bit hard to understand. And I was pretty thankful that from 2016 on, the recommendations from the guidelines went back to a fairly straightforward ABCD, high, moderate, low, or very low quality studies, and then one or two with being strong or weak strength of recommendations. So with that in mind, I'd just like to take you on a little journey over the years, which actually I've quite enjoyed doing, and I hope you will get some benefit from this as well. The first one is delivery room practice. In 2007, we were advised to use the lowest oxygen possible. Oximetry might help. Remembering saturations of 50 to 80% was normal at birth. We had a bit of evidence for that, a grade B for the lowest oxygen and D for the saturations. In 2010, we moved. We were being recommended to start our oxygenation at 30% and then move up or down. Use your oximeter, but noting saturations were actually 40 to 60% could be normal in a very preterm baby. And we were warned against hyperoxia. In 2013, there is a mention of blenders. Use a blender and start. We had a choice now, 21 to 30%. Use the oximeter on the right wrist and move your oxygen up and down. And I think it's fairly safe to say, currently where I'm working at the moment in Asia for a couple of months of the year, there are many hospitals that I work at that still don't have blenders. And yet this recommendation was a long time ago. But of course, there is a cost to neonatal care, and not everybody can afford everything. And that's certainly worth remembering. In 2016, we got a little bit of a dichotomy here, 30% for less than 28 weeks and 21 to 30%. If you're 21 to 32, once again, use your oximetry. In 2019, that was the same, but it added that 32 weeks and above, use air, once again guided by oximetry. And our latest delivery room practice advice is 30% at less than 28 weeks, somewhere between 21 and 30, your choice really, between 28 and 32, air above 32 weeks, and achieve saturations of more than 85% and a heart rate of greater than 100 by 5 minutes. So we can see an interesting change. I still think this 21 to 30% here certainly gives us leeway. What I do see, however, is very, very often in certainly deliveries that I attend and pop down very, very quickly. If a baby doesn't appear to be responding, you see 100% oxygenation used very quickly. I find that quite uncomfortable. It's certainly going to be necessary in some babies, but these recommendations can be quite hard to follow, particularly, I think, in the less experienced. This is a bit of a busy slide. However, I think it's fairly straightforward that delivery room practice for CPAP was really, in 2007, we were recommended to start at 5 to 6 centimeters with a mask or prong with a grade D type of recommendation. And this subsequently progressed. What was interesting in 2010, although that evidence had increased to B, we then had this consider sustained inflation to get an adequate FRC rather than IPPV. That was quite an interesting time, I think, where we were suddenly bombarded by lecture series of how sustained inflation was the best thing since sliced bread and that this was the way to move forward. And as you'll see later on, in 2019, that recommendation was actually rescinded. In CPAP 5 to 6, in 2013, we now have an A recommendation. We have the same in 2016 with the addition of positive lung pressure at 20 to 5 centimeters of water peak if an infant is apneic or bradycardic. In 2019, we have that same 5 to 6 centimeters mask or prong with the spontaneously breathing infants. And then we do not use sustained inflation as there is no long-term benefit. So what is sustained inflation? Sustained inflation technically is anything 5 seconds and above, usually 10, 15, sometimes even longer. And that certainly was being practiced, although no longer recommended from the studies that have been done. Certainly no long-term benefit, some evidence of harm. But I must distinguish this from a ventilation breath for newborn life support, which is a simple 2 to 3 second breath to help inflate the lungs. This is certainly not sustained inflation, which we would no longer recommend. In 2022, we now have our last recommendation. So we're CPAP 5 to 6, and we heard from Martin earlier that CPAP does seem to be used in some countries at a lower level. There is a fear of CPAP, and I agree with the CPAP phobia, or peepophobia, whatever it was called. And if apneic or bradycardic, then start ventilation breaths. Expert consensus is to start CPAP at 6 and PIP at 25 to 30. So that's moved on. That clearly has moved on. Although if we go back to 2007, it was still CPAP 5 to 6 centimeters. So we've just gained further evidence over the years. I thought I'd mention a bit about surfactant. Surfactant, this one is fairly straightforward. In 2007, babies with or at high risk of RDS should be given surfactant, as this reduces mortality and pulmonary air leak. And we had grade A evidence in 2007. In 2010 and 13, that evidence just had this word added, give a natural surfactant. And that's really because our synthetic surfactants really weren't as robust and certainly weren't giving us as good outcomes as the natural surfactant. Thank you. In 2016, once again, natural surfactant, we've got an A1 recommendation. And in 2019 and 2022, the recommendation is the same, but it now changes natural to animal-derived surfactant preparation. And I think that's probably what the vast majority of us are doing. Something else about surfactant. This is a bit of a busy slide, and I apologize. In 2007 and 2010, it was talking about surfactant prophylaxis. Give it within 15 minutes of birth to almost all, whatever that might be, of your babies under 27 weeks. And in 2010, it was almost all babies under 26 weeks. But prophylaxis should also be given to all preterm babies with RDS who require intubation for stabilization. In 2013-16, we had babies with RDS should be given surfactant early in the course of disease. So the 15 minutes has gone. It's early. A suggested protocol would be to treat babies less than 26 weeks when the FiO2 is greater than 0.3, and babies greater than 26 weeks when the FiO2 is greater than 0.4. I have to say, I do remember that causing a little bit of confusion of the arguments between 0.3 and 0.4 and whether a baby should or should not have received surfactant. And luckily, I think this was clarified. And in 2019, we had babies with RDS should be given rescue surfactant early. A suggested protocol would be to treat babies who are worsening when their FiO2 is greater than 0.3 on CPAP pressure of at least 6. So the 0.4 has disappeared. And in 2022, very, very similar again, but the suggested protocol to treat worsening babies when the FiO2 greater than 0.3, or if lung ultrasound suggests surfactant need. And we heard at the end of the last talk that lung ultrasound has become quite important and certainly being used much more now. And obviously it's appeared here as something that can be used to look at the infant lung to see if the RDS is worsening. So not a tool that we all have, not something that everybody uses, but certainly becoming much more popular. I thought it would be fun to look at the surfactant availability. I remember starting my days out, I think in the early 90s with ExoSurf, which obviously is no longer available, the Osiris trial, I believe it was called, as I was a young junior doctor. And we had a lot of choice. We have a lot of choices in surfactants over the years. What's interesting now, the licenses in Europe are just down to these 3. And I think most of you will recognize either Boractant or Boractant Alpha. I haven't used Bovactant, but I've certainly used most of the other surfactants around. And you'll hear about surfactant recommendations in a short while. So what about the dose? In 2007, the recommendations were already saying Boractant Alpha, an initial dose of 200, is better than 100 of Boractant Alpha or Boractant for treatment of moderate to severe. In 2010, and that's a B recommendation, in 2010 it becomes an A recommendation that using 200 of Boractant is better for the treatment of RDS. In 2016, the 200 better than 100 of Boractant or Boractant for rescue therapy, getting an A1. And our latest recommendations, no change from 2019, that an initial dose of 200 of Boractant Alpha is better than 100 of Boractant Alpha or 100 of Boractant for rescue therapy. So the Boractant Alpha has certainly gained in prowess over the years, because that 200 milligram per kilogram is a nice, relatively small volume compared to other surfactants, making it very difficult to give more than 100 milligram per kilogram of surfactant with other preparations. Apologies again for the busy slide, but the first 2 surfactant administrations you saw earlier, and I'll just mention 2007 of prophylaxis within 15, saying again in 2010. But what I want to come along to is 2013, where we first had considered the inshore technique, and saying more babies can often be extubated to CPAP or NIPBV immediately following surfactant. This requires clinical judgment. So this is leaving a lot to us, and I suspect we have huge variations in clinical judgment. In 2016, once again, we have inshore is considered for infants who are failing on CPAP. LISA or MIST have come in now and may be used as alternatives for spontaneously breathing infants. So LISA or MIST came after inshore, less invasive and minimally invasive. And by 2019, we have LISA being the preferred mode of surfactant administration for these spontaneously breathing babies on CPAP. The caveat in 2019 was provided that clinicians are experienced with this technique. That's disappeared from 2022, and judging by the amount of workshops that I've seen online and advertised for LISA workshops, I think most of our trainees and most people now are pretty confident at using LISA. Although the exact way LISA is done, we could probably have another talk about sedation or not sedation, but I'm not going to go into that here. Surfactant dosing, pretty simple, really. Pretty early on, it said second, sometimes a third dose of surfactant should be administered if there's ongoing evidence of RDS, a persistent oxygen requirement, and need for mechanical ventilation. It says the same from 2019 onwards, but just puts the caveat and other problems have been excluded. I think what's interesting here is there's no mention of timing. And timing is quite interesting. I still see some people writing up a second dose for 12 hours or saying you can't give a second dose for 12 hours. Now, I remember that in the 90s in the OSIRIS trial where that was the agreed protocol. But there's nothing to stop you giving a second dose of surfactant within an hour or 2 or 3 or whatever, whenever you deem the baby requires it. So there are some of those old practices that have hung on, and this guideline actually doesn't mention about timing, but just says a second and sometimes a third could be administered. We are going to hear about oxygen later on, but I thought I think this is interesting because this really has changed, and we did have some pretty interesting evidence for the changes. In 2007, we said babies receiving oxygen saturation should be maintained at all times below 95, as this reduces ROP and BPD. But it was a kind of a D evidence, so not much. In 2010, babies receiving oxygen should be maintained between 85 and 93. So once again, the evidence still small, but that's where we're recommending now. But in 2013, this goes up. So from 85 to 93, we've now got 90 to 95. And clearly some new evidence was coming out about the harmful, in fact, the increase in mortality in infants with a lower saturation, particularly from some of the trials that we heard of in the earlier talks. And literally from 2016, it's pretty much made the same. In preterm babies receiving oxygen, the saturation target should be between 90 and 94. We have B2 evidence on that. And it doesn't look like it's going anywhere soon, to my knowledge, although maybe from your next talk, you will get some more information. And I look forward to listening to that. Mechanical ventilation, we heard a little bit about that. But in 2007, we have this statement that says all modes of mechanical ventilation can induce lung injury and should be limited to the shortest possible duration, which I think we would all agree with, provided there's a reasonable chance of successful extubation, which of course we're having huge discussions about now in the first talk about extubation, whether it be to CPAP or an IPPV with its slightly higher mean CPAP. In 2010, you recommended that mechanical ventilation should be adjusted frequently. In other words, keep an eye on the baby. I often say, being one of those old guys, we used to sit next to our babies with the ventilator and watch the baby, try and synchronize them, adjust all the time. Nowadays, I think a baby goes on a ventilator and you can walk away fairly quickly. Whether you should or not is another question, but adjusting frequently means you need to not walk away. In 2013, we hear about the targeted tidal volume. This should be employed as it shortens the duration of ventilation and reduces BPD, and we have an A there. So the TTV, the studies coming out with the reduction in BPD and other parameters are really showing that targeted tidal ventilation really is the mode that we should be using when we ventilate infants. It shortens the duration of ventilation, reduces BPD, and in 2016 we had this, and reduces intraventricular hemorrhage. In 2019, we have a change. The primary choice of ventilation mode is at the discretion of the clinical team. That's giving you freedom to practice. However, if conventional ventilation is used, then targeted tidal should be employed. And in 2022, we have another addition. So the current recommendation is lung protective modes such as VTV or high frequency oscillation. We've heard a little bit about high frequency just now from Martin. Should be the first choice for babies with RDS who require mechanical ventilation. So these are our current recommendations. And we heard a little bit about the ventilator availability. I think we've always felt sorry for our North American colleagues who have really struggled to have a ventilator that ventilators can do this all in one machine, and we're very, very lucky. Certainly in the UK with SLE and with Accutronic, and yes, we have the Draeger as well. Although we wouldn't regard that one as the best oscillator in the bigger baby. But those are the strategies that are recommended. Caffeine, well, 2007, no recommendation. 2010, it starts to be recommended for all babies. It says particularly less than 1,250 grams who are managed on CPAP or NIPPV. This recommendation continues, 2013, who are managed on non-invasive sport. And in 2016, we have early caffeine should be considered for all babies at risk of needing mechanical ventilation, such as those less than 1,250 grams who are managed in non-invasive. In 2019, the weight category disappears. Early caffeine should be considered for babies at high risk of needing mechanical ventilation, such as those on non-invasive respiratory support. And in 2022, pretty similar for babies at high risk of needing mechanical ventilation, such as preterm babies on NIV. So the early caffeine really being considered now for all babies rather than initially just the smaller babies. Once again, here, in which babies caffeine should be used in babies with apnea and to facilitate weaning, recommendations in 2010 and 13, 2016 and 19 to facilitate weaning with A1 evidence. And in 2022, we get given the dosage. Caffeine, 20 per kilo loading and 5 to 10 maintenance should be used to facilitate weaning from mechanical ventilation. And I think that's pretty standard. It's been around a long time, but interesting that we're now getting recommended a dosing that we should use, although looking at that dose, it does look very familiar. Dexamethasone, 2007, 2010, no recommendations for dexamethasone for weaning. But from 2013, we've had the similar recommendation right the way through to 2022, where a short tapering course of low-dose dexamethasone should be considered to facilitate extubation in babies who remain on mechanical ventilation after 1 to 2 weeks. And that's A evidence with 2 with a not a strong but a weak recommendation. And so that's essentially a part. There are other things in the consensus guidelines, but I think it's been very, very interesting to see how it has evolved over the years. And if you've been in neonatology for many years, we have all changed our practices as the evidence has come forward. And of course, there are emerging technologies. There are new things that are coming our way. ILCOR, the International Liaison on Resuscitation, we get the consensus every 5 years. And many newborn stabilizations are based on evidence from this document. But 5 years is a long time to wait. And as you see, publications are occurring all the time. And just having a quick look at some of the literature about how babies may benefit at delivery, full resuscitation with the cord intact. We're now seeing that come into play and being researched. I think people are looking for simpler ECG monitoring, and I'll come to that in a bit. Further exploration of cerebral oxygenation. NIA is interesting, is actually comes quite low down on the list as to whether it's going to be beneficial or not, although of course there's some absolute advocates for NIRS who are desperate to use it, but I'm afraid the evidence at the moment is pretty thin. Tidal volume at resuscitation. This is an interesting one because studies are showing that 50% of the time we're actually giving more than 6 mils per kilo. So are actually be causing the damage within the first 60, 90, 120 seconds of delivery. Have we already caused irreparable harm by what we're doing on the resuscitator? We heard a little bit about electrical impedance tomography, or it was mentioned. And although this is used as a research tool, and we certainly had this at the Corniche for a while, looking at it and giving us some very interesting data, looking at lung changes. This could really, I think, if it wasn't so difficult and awkward to use on these infants, it could really help us assess lung changes. It may be in a way that lung ultrasound has done, looking at post-surfactant, looking at ventilation itself or extubation assessment, even body positioning and the effects of suctioning. Electrical impedance tomography may well be a tool that can help us. I've seen video laryngoscopy coming in. The data would, well, it would show improving first-time intubation, but of course, most of the video laryngoscopes have large blades, and there's a problem with prematurity. And then the video laryngoscope goes missing, and then the staff that we're training then can't intubate without it. So I have mixed feelings about video laryngoscopy. I hope it just becomes a little bit, perhaps a little easier to use and a little more subtle in the future. I think the future, what will be really interesting is the use of holograms. I think I don't have any pictures to show you of what holograms may look like, but that looks quite exciting technology that could well be in the future, helping us with our practicalities. There are decision supports via an app, so you can have your app to help you with your baby, guided by simple algorithms. Retrospective video reviews are quite interesting because that's a great learning experience when you've been at a resuscitation and think you've done your best, because we can always learn. Telemedicine consultation to perhaps reduce transfers and save babies from difficult and complex transports, long distance transports, which may do more harm than good. And of course, contactless monitoring would be fantastic. Without leads and cables slipping off and exposing infants to gain access to them, that would be a great innovation. So lots to come, I think, and lots of that will need to be assessed, and then it'll take time to get into consensus management. I found this paper in Pediatric Research, which was quite interesting, which was a key monitoring survey, the newborn delivery room of tomorrow. So emerging in future technologies. And if you look at what this group of survey respondents, 60 respondents, looking at what was very important to them for the delivery room of tomorrow was easier or simpler ways of heart rate, saturations, temperature, mask leaks, tidal volumes. Not so important cerebral oxygenation or CO2 measurements. I mean, this is just a view of opinions, but quite interesting to see what people think are the relevant areas when resuscitating an infant. And looking at future technologies, what do they therefore think would be useful? And as you can see, video analysis comes in here quite highly as important. Lung or aeration volume, highly important. And I think looking at the studies that show that we're often overinflating the lungs gives us an idea of why people think this is important. Wireless vital signs. Wouldn't that be great if we could have wireless vital signs? Contactless vital signs, another one there. So all fairly important. AI and our near-infrared extrauterine systems coming fairly low or maybe important. So if that's a consensus, maybe we're going to see future technologies which will be able to help us initially, but also not just initially while we're ventilating, while we're looking after these infants. I found this very interesting looking through what we've done over the years, because I realized that many of those areas that we've all had to change practice, and change is very difficult. And I think change does take time, and change takes money. And because I do work in developing countries, some of the simple things still aren't there for many people. As we get more and more technical, as technology advances, then I think we're going to have more equipment, we're going to have more toys to play with, and perhaps it'll widen the gap even more between institutions. I don't know, but advances come at a cost. But I do think measuring improvements in outcome is difficult. If we've seen from the evidence, B's and C's, and from the consensus management, some of the areas where we're basing our practices are really quite thin. The evidence is very small, and therefore that's why we have consensus guidelines. We think it's the best thing to do. We don't always know, and I think that's very difficult. So I usually end my talk by realizing that I should be retiring probably, because I think, do we continue to push the boundaries with further increase in death and greater morbidity in survivors? Is neonatology about looking after 21 weekers, 20 weekers, and getting lower and lower, because the complications they haven't gone away. We haven't removed chronic lung disease. We haven't removed many of these chronic morbidities. Or should we just concentrate on preventing or delaying premature delivery in the first place? For me, that's my ideal dream as a neonatologist. Put me out of a job. So I hope that was an interesting run through. I've been delighted to chat to you today, give you some thoughts, and I wish you all well, and hope that was helpful. Thank you very much.
Thank you very much, Julian, for the very informative presentation and the depth of the European consensus that you gave, starting from the beginning to the end. And let me ask you a question. Dr. Kessler mentioned about the European phobia of PEEP. Since you're reviewing the European consensus guidelines from the start till now, what's your answer to Dr. Kessler through the European consensus that you have reviewed from the start?
Well, I could be quite political now in saying, as the UK is no longer part of Europe, I do regard ourselves as very separate. And as you saw, he did have a separate column for the British Isles. So, well, the European consensus has actually started off its guidelines at 5 to 6 centimetres. And when you looked at Martin's average on one of his studies, people were barely achieving 5 to 6 centimetres. I think some of the research papers he was showing, one of the trials that's going on, are using quite low PEEPs of 3 and 4, which I would agree with Martin. I really think we've learned that that's too low. I mean, I've taught and believed in open lung for many, many years, and worked with Peter Rimmensberg in Switzerland, who is a great advocate of open lung ventilation, and I do think these low PEEPs are potentially quite harmful. And if the lung is not open, you're going to damage it. And the collapse, a repeated collapse, is simply, for me, it's just simply not good enough. So, do I see it? Well, I don't see it in the practice. Working in Asia at the moment, I'm seeing PEEPs of 5 or 6. People are very frightened of 8. I do see people frightened of 8 centimetres in a number of places, but I wouldn't say, I don't work a great deal in Europe. I pick up babies from Europe. They seem to be on PEEPs of at least 5, so I can't really fully answer your question there, Hisham. But I would just agree with Martin that I think PEEP is quite important, and we shouldn't be frightened of it.
Sure. The first 2 speakers actually mentioned about the limited data for the population below 28 weeks. My practice, and I think others practice also, they tend to give PEEP, more higher PEEP for this population. And they use the higher PEEP, 6 and above, for the tiny population before below 28 weeks. Maybe they will not use the same PEEP for the bigger population. They will use like 5 or 6 maximum. Is there any mention about any distinction in the European guidelines about like differentiation of the level of PEEP between these two population above and below 28 weeks?
No, there isn't. No, there isn't. Only the only differentiation you see is with the FiO2 recommendation at starting resuscitation. I think also what's important, what was said, is that pre and post surfactant. I mean, I think you need surfactant to have the most benefit for the PEEP, and for PEEP working in an immature lung without surfactant is clearly going to struggle. So I think from my point of view is early surfactants and and use your PEEP. I think if you're using high PEEPs and you haven't given surfactant, that may well be an issue. But no, it doesn't distinguish between gestation or weight. No.
Okay. I think will be the questions for us, as for you, as we are actually very limited on the time.
Yeah.
I'd like to thank you very much for being with us tonight, and it was actually a pleasure working with you, and a pleasure always hearing your presentation. So thank you very much for joining us tonight.
Thanks for the invite, and great to see you all. And thank you.
Thank you very much. Thank you. Okay, I want to ask, as I said earlier, Dr. Ruben Alvero actually had a problem in his hospital, as they don't support Zoom anymore. So he had a problem to present his presentation from the hospital. He recorded and sent it to us. Mr. Dia, is his presentation ready? Okay, so Dr. Ruben Alvero is actually, as I said, recorded
first of all, I
his
want to
lecture.
thank the organizer.
Mr. Dia, if you can pause 1 second, let me just present Dr. Ruben Alvero. So Dr. Ruben Alvero is the medical director of the neonatal sleep lab at the Health Science Center. He's a former division chief and associate professor of pediatrics at the University of Manitoba. Dr. Alvero is neonatal professional activities have encompassed education, research, administration, and clinical care. His main research focus has been on control of breathing and respiratory care in the fetus and the newborn. He actually collaborated and participated in a lot of randomized control trial, international and national, and he published over 200 original papers. So Dr. Ruben Alvero actually is one of the experts of the respiratory care all over the world now. And it's our pleasure to have him joining us tonight. And he will talk to us about and this actually very interesting area to me in particular. As the saturation limit in the Canadian practice is a bit different from maybe USA and Europe. So he will tell us about the optimal saturation limit values in the newborn infants, and it's his Canadian experience. Okay, we can play the video, please.
First of all, I want to thank the organizer of this symposium for allowing me to present this important topic today. The title of my presentation is Optimal SpO2 Values in Newborn Infants. And I have nothing to disclose. Controversy about optimal oxygenation in preterm infants has existed since the unrestricted use of supplemental oxygen caused an epidemic of retinopathy of prematurity in American nurseries in the 1940s and 1950s, which was followed by an increase in death and cerebral palsy in subsequent years due to restrictions placed on oxygen delivery. So avoiding hyperoxia and hypoxic events became a choice between two evils. And this persisted when continuous monitoring with pulse oximetry became the standard of care in NICU in the 1990s. So here we are in 2024, and we still don't know how much oxygen we give to our patients to minimize the risk of hyperoxia and the risk of hypoxic events. So what are the actual goals of oxygen therapy? And I would say there are two main goals of oxygen therapy. The first one is to optimize oxygen delivery to the tissues. The reason we need to do that is because we need to prevent the development of anaerobic metabolism, lactic acidosis, and of course tissue hypoxia. We also need to avoid the development of hypoxic pulmonary vasoconstriction that is usually associated with tissue hypoxia. Now, we also know that tissue hypoxia is associated with an increased mortality, is also associated with increased risk of NEC, PVL, and also impaired neurodevelopmental outcome. And also tissue hypoxia in a chronic basis is associated with poor growth. Now, the second goal of oxygen therapy should also be to minimize the oxygen stress due to excessive supplemental oxygen, because we know that this is also associated with bad outcomes that includes ROP, BPD, HIE, PVL, IVH, NEC, and also impaired neurodevelopmental outcome. So I'm just going to go over some basic oxygen physiology that will help us to determine the optimal oxygen target for our patient. So first we need to differentiate between hypoxemia and hypoxia. Hypoxemia is just low PO2 levels. However, hypoxia is defined as inadequate oxygen delivery to the tissues. And that involves way more than just a low PO2 levels. Why? Because it depends on the oxygen carrying capacity. And that arterial oxygen content depends not only on the PO2, but more importantly, depends on the hemoglobin concentration and the saturation of that hemoglobin. But not only depend on that, but depends also on the cardiac output. And the cardiac output depends on the stroke volume and the heart rate. So there are many factors that will determine how well the oxygen gets to the tissues besides PO2 levels. So you can actually have hypoxemia without hypoxia. And the classical example is a baby with cyanotic heart disease in which the PO2 is low, but compensatory mechanisms allow to have reasonable tissue oxygenation. You can also have hypoxia without hypoxemia with a normal PO2. Classical examples of this is severe anemia, CO2 poisoning, or poor cardiac output. All this will cause tissue hypoxia without having an abnormal PO2 value. So what's the correlation between PO2 and SpO2 according to the type of hemoglobin? So we know that neonates have an increased levels of fetal hemoglobin, which has a high affinity for oxygen. So the dissociation curve of the fetal hemoglobin is shifted to the left compared to the adult hemoglobin. And this is an important factor to consider when we set SpO2 targets. Because the fetal hemoglobin shifts the oxygen dissociation curve to the left, that results in high oxygen saturation at PO2 levels that could be well below 50. We also know that the proportion of fetal hemoglobin increases with decreasing gestational age, so that the concentration of fetal hemoglobin is close to 90% in babies under 29 weeks. And that concentration will decrease as baby gets older or the baby gets transfusions with adult hemoglobin. So here we have a picture that shows the difference between the two hemoglobins. In red, we have the fetal hemoglobin, or the left, and in blue, we have the adult hemoglobin. And as you can see, the fetal hemoglobin, when it's saturated at 50%, the PO2 is about 20. When the adult hemoglobin is saturated at 50%, the PO2 is higher, usually about 28 or so. When the fetal hemoglobin is saturated at 90%, the PO2 is usually in the low 40s, while the adult hemoglobin at 90% saturated is usually close to 60. So you can see the difference between PO2 at the same saturation levels according to the hemoglobin. Now, when we look at the range of saturation that we usually keep our babies between 85 and 95, on those ranges, the fetal hemoglobin will have a PO2 usually between 36, 37, and 55, 56, which is significantly lower than when the baby has mostly adult hemoglobin, usually after transfusion or at greater postnatal age, in which the same saturation range of 85 to 95 will give us a PO2 that is much higher, usually between 50 and 70. So at any level of SpO2, PaO2 is lower with fetal hemoglobin than adult hemoglobin, thus increasing the risk of hypoxemia and decreasing the risk of hyperoxemia. At any level of SpO2, the PO2 is lower with blood acidosis, pH usually less than 7.25, and during hypothermia, because those two factors will move also the hemoglobin dissociation curve to the left. At any level of SpO2, PaO2 may be lower in infants with dark skin due to the accuracy of pulse oximetry, putting them at risk of occult hypoxemia. And this, again, is a problem with the monitor itself. We know also the risk of severe hypoxemia increases exponentially when the saturation goes below usually 87. And we also know that the risk of hyperoxemia increases exponentially when the SpO2 is over 96%. So, despite the changes in concentration of fetal hemoglobin, the changes that we see with different gestational age and postnatal age, we also see that there are a lot of factors that will cause fluctuation in oxygenation in preterm infant. Now, the most important factors that cause those fluctuations are first the immaturity of the respiratory control system in preterm infants that predispose them to breathe irregular with a lot of periodic breathing and apneas, and that will definitely cause fluctuations in oxygenation. Many of these babies will have airway obstruction that will also cause desaturations. Most of these babies, especially the tiny ones, will have low lung volumes or FRC due to atelectasis and increased chest wall compliance that will also put them at risk for significant fluctuations in oxygenation. In babies with chronic lung disease that develop pulmonary hypertension, that will also increase the risk of fluctuations and desaturations. Babies that are intubated and they're having ventilatory asynchrony, they sometimes develop forced exhalations, and that will also cause significant desaturations and fluctuation in baseline oxygenation. And finally, we have respiratory equipment malfunction or interface displacement that will also produce significant fluctuations in oxygenation in our patients. So how do we objectively assess the degree of hypoxemia and hyperoxemia? And for that, we use the SpO2 histogram. This histogram will tell us how much time the baby spent on each saturation range over time. And we can change that saturation range to be show over 2% intervals, or we can make it a standard, usually 5% intervals. and here will show us what percentage of time the baby is spending on each one of those saturation ranges. So the SpO2 histogram represented as a cluster bars, each bar representing the percentage of time spent with a particular range of SpO2. They can be used for real-time data and trended data like heart rate and respiratory rate, and answer the question for how much trends over a period of time, and its regular use may actually improve time at goal saturations, may also decrease the rate and or severity of comorbidities, and also identify infants in need of is to have the target, the time, usually about 80% of the time within that target. Now, that's not usually easy to accomplish, especially in babies that are having a lot of fluctuations. And I'm going to give you now what we consider that is acceptable at each saturation level. So you shouldn't have more than 4% less than 80% saturation in any babies, except in babies that has significant right to left shunt, usually due to cyanotic heart disease. It should be less than 10% below 85% saturation, except in babies with severe right to left shunt or cyanotic heart disease. Babies should not have more than 14% or so below 90% at any time, except in patients with severe lung disease or severe right to left shunt. So most our babies, usually above 32 weeks post-menstrual age, or any patient with pulmonary hypertension should have at least 80% of the time spent between 90 and 95%. And we should try to avoid any time above 95%, unless the baby is in room air, in which there is no limit for which the baby could be above 95%. So the ideal oxygen saturation target remain unknown until the recent large collaborative trial that compare two different oxygen saturation targets from birth in extremely low birth weight infant. And that was put together by the NEOPROM, or Neonatal Oxygen Prospective meta-analysis, that combined the data from 5 different RCTs from 5 different countries that study nearly 5,000 infants less than 28 weeks that were randomized different time from birth to 2 different levels of saturation target. One was the low saturation target, was kept between 85 and 89%, and the other group was the high saturation target, 91 to 95%. So here I'm going to show you the summary of those meta-analyses. When they look at the primary combined outcome of death and neurodevelopmental impairment, there was no significant difference between the 2 groups. And also when they look at disability alone, including blindness, between the 2 groups, there was no significant difference between the two groups. However, when mortality was assessed in isolation, there was a significant increase in mortality, about 2.8% increase in the low target group, 85 to 89%, compared to the high target group. And there was also a significant increase in NEC, about 2.3% increase in the low saturation target. However, the high saturation target had a significant increase on CVROP that was up 4% compared to the low target group. And as expected, because they were aiming for high saturation, therefore this baby needed more oxygen for longer time. The BPD rate was significantly higher in the high target group, and also when they look at the physiologic BPD, although this was not statistically significant. So in summary, the NEOPROM study showed that for every 31 to 40 infants targeted at a lower oxygen saturation range of 85 to 89%, there was one extra death and one extra case of NEC, and one less infant with severe OP and 8 days less on oxygen therapy. So what do we learn from the NEOPROM studies? The NEOPROM provides little guidance on where to set the oximetry alarms and how to respond to them. Not using SpO2 target of 85 to 89% does not necessarily mean that infants have to be treated with a desired SpO2 target of 91 and 95%. The risk difference on mortality and ROP will be larger in centers with high mortality and ROP rates and vice versa. And also we know that after the NEOPROM publication, there was several single center studies that showed that the ROP rates were up when they changed the oxygen saturation target to 91 to 95% without seeing a significant decline in mortality. So that's important to take into account. Now, the NEOPROM study have a lot of limitations. I'm going to summarize the most important one here. First, all 5 trials reported less separation in SpO2 between treatment groups than anticipated, because the lower SpO2 target group had higher than intended saturation levels. So the nurses always are less responsive to hyperoxia than hypoxia, so they usually try to keep the sats a bit higher. There were 2 trials, the BOOST 2 in UK and the Australia trial, that were stopped earlier because they saw the increased risk of mortality, which may have resulted in some overestimation of the effect on mortality. Potential for false positive results based on multiple comparisons from 16 different outcomes and hundreds of subgroup analyses means that individual comparisons should be considered exploratory and interpreted cautiously. And finally, I would say one of the most important limitations of the NEOPROM studies is that none of the 5 trials allow for changes in SpO2 target according to different clinical conditions, different gestational age, on different postnatal age. So I'm going to discuss that right now. So why the SpO2 target should be adjusted based on gestational age and postnatal age? Well, first of all, it's because the risk of hyperoxemia is greater at lower gestational age, predisposing these infants to ROP and BPD. The risk of chronic intermittent hypoxemia is greater at greater postnatal age, and that has been associated with worsening ROP, respiratory instability, neurodevelopmental disability, and also an abnormal growth pattern. Now, to explain the chronic intermittent hypoxemia, I usually use the picture of an iceberg. In the iceberg, we see the ice that is on top of the water. That's the only ice that the nurses see. And that's what we describe as what they call apnea prematurity. This is what the nurses record in the bedside sheets, the baby bedside. However, the nurses fail to see all the chunk of ice that is under the water that is significantly greater than the tip of the iceberg, and that is what we represent the intermittent hypoxemic events. And the only way to see this is by looking at daily histogram and see how much time the baby spending below the SpO2 targets. Now, this is a study done by Di Fiori in Cleveland that look at a group of babies under 29 weeks that were followed for the first 8 weeks of life, and they look at the number of hypoxic events measured by number per week, and they define hypoxic events when the saturation went below 80% for at least 10 seconds. And as you can see here, they show that those events were relatively low, very few in the first 2 weeks of life, but there was a significant increase in the number of events after the second week of life, at that plateau about 5 to 6 weeks of age, before starting a slow decline by weeks 7 and 8. Now, the most likely reason these events were few in the first 2 weeks is because the first 2 weeks the lungs are still undamaged relatively. The fact that the concentration of fetal hemoglobin is still very high, usually before transfusions, and the activity of the peripheral chemoreceptor still relatively low, which predispose these infants to a more regular breathing pattern. Now, the significant increase in number of hypoxic events that they saw after the second week of life was likely related to the fact that the lungs now had been damaged by the ventilator and the oxygen toxicity, the fact that many of these babies had been transfused and they were having mostly adult hemoglobin, and the fact now that the peripheral chemoreceptor activity was high, predisposing them to significant irregular breathing pattern and periodic breathing. And the reason why these events started going down after the week 6 of life is maybe because the lungs were getting better. The PO2 was higher, and that brought the activity of the peripheral chemoreceptors down, and that allowed for baby to have a more regular and stable breathing pattern. Now, the same group of investigators showed that when they study and they follow a group of babies between 24 and 28 weeks, they documented a significant association between hypoxic, intermittent hypoxic episodes and the development of severe ROP requiring laser therapy. As you can see here, the black square represent babies that require laser therapy because of more severe ROP, and the black triangles represent the babies that did not require laser therapy. And as you can see, the babies that require laser therapy have significantly more desaturation events per week compared to the baby that had less severe ROP. So while hyperoxia is the most important risk factor for ROP, this data support the belief that fluctuations in oxygen saturation also represent a significant risk factor for ROP. So why is the relationship between PO2 and intermittent hypoxemia important? Here we have a graph that shows the relationship between arterial PO2 on the horizontal axis on the bottom and the peripheral chemoreceptor impulses per second represent the activity of the peripheral chemoreceptors on the vertical axis. And as you can see here, the PO2 in a normal adult is usually between 90 and 100, and that PO2 is too high for the peripheral chemoreceptors, so the peripheral chemoreceptors are basically silent. However, in term infant, that PO2 is slightly lower, usually between 60 and 80, and that start increasing the activity of the peripheral chemoreceptor because they're sensing a lower PO2. But look at what the preterm are sitting at. They're sitting at a very steep part of the curve when they have a PO2 between 40, 50, or 60. and that represent that the lower PO2 will cause significant activity of the peripheral chemoreceptors, and that greater activity will cause significant swings in ventilation because the PO2 is never stable at that level. So ventilation goes up and down significantly with minor changes in PO2 because they are sitting in the steep part of the curve. And that will cause significant fluctuations in PO2. So how do we adjust the SpO2 target according to postnatal age while receiving oxygen? Well, if we want to limit the suppression of normal retinal vascularization due to hyperoxia, we should maybe aim for lower saturation levels in the first few weeks of life, maybe up to 32 weeks, and have the saturation target set between 87 and 94%, and try to aim for higher sats after 32 weeks to limit the retinal vascular overproliferation that is usually triggered by intermittent hypoxemia. And after 32, 33 weeks, maybe we should aim for sats between 90 and 95. Now, what are the current guidelines recommend? Well, if you look at the European consensus guidelines that was published in 2023, first they said that in preterm infant receiving oxygen, the saturation target should be between 90 and 94. The quality of the evidence for this recommendation was judged to be moderate and the strength of the recommendation weak. The second recommendation is that the alarm limit should be set at 89 to 95%. Again, the quality of the evidence of this recommendation was judged to be very low and the strength of recommendation weak. Now, when we look at the American Academy of Pediatric guidelines that were published in 2016, they say that the ideal physiologic target range for SpO2 is likely patient-specific and dynamic and depends on various factors, including gestational age, chronological age, underlying disease, and transfusion status. They also say that recent RCTs suggest that a targeted saturation range of 90 to 95 Now, when we look at the American Academy of Pediatric guidelines that were published in 2016, they say that the ideal physiologic target range for SpO2 is likely patient-specific and dynamic and depends on various factors, including gestational age, chronological age, underlying disease, and transfusion status. They also say that recent RCTs suggest that a targeted saturation range of 90 to 95 may be safer than 85 to 89%, at least for some infants. So as you can see, they are very vague on their recommendations. Third, regardless of the chosen target, an upper limit of approaching 95% while the infant remains on supplemental oxygen is reasonable, and a lower alarm limit will generally need to extend somewhat below that lower target. So there's a lot of unanswered questions regarding SpO2 targeting in newborn infants. First, we don't know the optimal SpO2 for these infants. We don't know if targets should be differ between the most immature and the most mature infants. We don't understand fully why there is a higher mortality in the low saturation group. We don't know whether SpO2 targets should be fixed or should be gradually increased as the child matures. We don't know whether small gestational age infants should be treated differently than adequate for gestational age infants. And it's not clear whether absolute values or fluctuation in SpO2 play a main role in the hyperoxic or hypoxic damage. So I'm going to show you what I think we should use as SpO2 targeting, and this should be changed according to the clinical condition, the gestational age, and the postnatal age of our patient. So what we call the precision medicine approach to SpO2 targets. Again, because the risk and consequences of hypoxemia and hyperoxemia vary based on different gestational age, postnatal age, and clinical condition, the SpO2 target should reflect that. So here we have a bar that shows the saturation range between 85 and 100%. We should definitely avoid any saturation above 97% in any infant, on any clinical condition, any gestational age, any postnatal age, unless the baby is in room air. Otherwise, nobody should have saturation above 97%. Also, nobody should have saturation below 87% unless the baby has congenital heart disease with a fixed right to left shunt. So infants below 28-week gestational age without pulmonary hypertension after transfusion, we should aim for SATs between 87 and 94%. Preterm infants less than 28 weeks with pulmonary hypertension, dark skin, or higher fetal hemoglobin, usually before transfusion, should have slightly higher saturation target, usually 89 to 95%, to prevent hypoxemic events. Preterm infants over 32 weeks, regardless of the condition, should have SATs slightly higher, between 90 and 95%. Late preterm infants, term infant with pulmonary hypertension, hypothermia, requiring usually FiO2 less than 0.6, pH less than 7.25, or dark skin should have a higher saturation values, usually between 90 and 97%, because the risk of BPD and ROP is indefinitely lower in this group of babies, so we shouldn't be so afraid to aim for higher saturation target. So here is a summary of my suggestion recommendations. Again, these are not based on randomized clinical trials because we don't have those according to different gestational age, postnatal age, and clinical condition. But this is what we use in our units. First, a narrow SpO2 target of 85 to 89% should not be used clinically, as it may be associated with increased mortality, as was clearly shown by the NEOPROM study. For practical purposes, SpO2 targets should be the same as alarm limits, as bedside nurses react to the alarms and not the SpO2 target. It may be safer to use wider intermediate SpO2 targets such as 87 to 94%, and those are alarms setting at those levels. Infants with high concentration of fetal hemoglobin, usually in the first few days of life, usually before transfusion, may need higher SpO2 targets to avoid hypoxemia, and the target should be usually a bit higher, 89 to 95%, and especially if they're requiring low concentration of oxygen. In ICUs with high risk of severe NEC and mortality will likely gain more by targeting higher saturations than in ICUs where the risk of these outcomes are low. In ICUs with low risk for treated ROP will likely tolerate targeting higher saturations better than in ICUs where the risk of ROP is high. Set the averaging time of the monitor to 12 to 16 seconds when the baby is in ICU, but that average time should be reduced to 2 seconds while the baby is being managed in the recess area to have a higher sensitivity for desaturation. Preterm infants more than 32 weeks should have higher SpO2 targets, 90 to 95. Preterm infants more than 32 weeks with BPD or threshold ROP should have even higher SpO2 target to prevent intermittent hypoxemic events, and usually the recommendation is 90 to 96%. In late preterm infants and term infants with PPHN, therapeutic hypothermia, pH less than 7.25, FiO2 less than 0.6, or dark skin, maintain preductal SpO2 between 90 and 97, with usually a PO2 between 50 and 80 millimeter. Now, things that the NICU community should try to study in the next few years is first to identify reliable and valid measures to monitor tissue oxygen sufficiency at the bedside. Continue evaluation of closed loop system, nurses versus machine, to determine which one is better to keep the SpO2 target in a better way. Monitor outcomes in response to policy changes of oxygen therapy in extremely preterm infants. So if your unit is planning to change your saturation target, you should monitor those changes. You should look at the outcomes before and after, and see if you are actually making a difference by changing the target saturation. And finally, studies on whether absolute values or fluctuations played a main role in the hyperoxic and hypoxic damage. And this is my last slide, and thank you very much.
Finally, Robin Alvaro for this very nice presentation, tackling actually an important issue in our NICUs. Unfortunately, Dr. Robin Alvaro had a technical problem and he will not be able to join us for question and answers. I only have one comment on Dr. Robin Alvaro, that I second him on changing the target saturation based on the clinical scenario, especially for the population less than 28 weeks. I tend to favor probably the lower Canadian limit of saturation for those population than the American recommendation. They accept saturation 87 to 93, and by accepting this a little bit lower saturation, as we know, the nursing staff, according to the research, can miss about 50% of the alarm. 50% of the time they will miss the alarms. So accepting higher saturation than that for this population probably predispose them to more ROP. And the Canadian, as I said, little bit accept lower saturation to make the saturation limit far from the ROP zone. Probably this is, as to me, favoring the Canadian limit of saturation, and that's why I asked Dr. Alvaro to present his experience. And again, I thank him very much for the nice presentation. And I actually, it's unfortunate that he can join us for question and answers. So finally, I'd like to thank all our speakers who presented very elegant presentation tonight, adding to our experience, and hopefully it will help us managing our sick babies in the NICU. Dr. Amit Mukherjee, Dr. Martin Kessler, Dr. Julian Eason, and finally Dr. Ruben Alvaro. I also like to thank our chairman, Dr. Iyad Saada, for chairing the first two sessions. And finally, I'd like to thank Pearl Management, Mr. Mawfaq al-Shamali and his team, and Mr. Dia, who've been facilitating this event tonight. At the end, I'd like to thank you. And as I said in the beginning, this is an introduction to our multi-specialty conference, which will be physically in Abu Dhabi in 13, 14, and 15 of September this year, inshallah. I hope to see you in further and more online events, and of course, to see you in our physical conference. I'd like to thank you all for attending this session. I hope it was beneficial and adding to your knowledge, and hopefully it will reflect on your practice, inshallah. Thank you very much, and see you all in our next event. Thank you.